Good evening, everyone. I am Dr. Poonam Shah from Integra's Pharma, and I would like to invite you all and welcome you all for today's webinar on Optimizing Pregnancy Care second series by ISOPAC Mumbai chapter, an educational grant by Integra's Gynecology. Before we move on to today's session, I would like to give you a small brief about Integra's. The journey of Integra's began in the year 2018, and since then, we are among the youngest top 85 pharma companies in India. And among that, we have been ranked as 13th in the gynecology represented market. Trusted by more than 42,000 Indian doctors and more than 5,000 gynecologists, we are leaders in two therapy areas, ANC care, wherein we have the progesterone and hematinics, and vulvovaginal infection management. To take this session ahead, I would like to invite and introduce Dr. Komal Chavan. Dr. Komal has done her MD, DNB, MNAMS, FCPS, DGO, and FICOG. She has also done Diploma in Reproductive Medicine from Germany. Dr. Komal is a medical director at Chavan Maternity and Nursing Home. She is an honorary professor at Dr. R.N. Cooper Hospital and HBT Medical College. She is a chairperson at Foxy Medical Disorders and Pregnancy Committee. She is a member for the Managing Council MOGS, member for the Managing Committee AFG, a joint secretary to ISOPAB Mumbai chapter, an editor for the Psychological Issues in Obstetrics and Gynecology, again an editor to Monogram on Hematological Disorders in Pregnancy. Other than this, Dr. Komal has also received various awards like the Foxy Championship Award, the Wonder Foxy Award, the Foxy Youth Mela Award, among the many awards. So I would like to welcome Dr. Komal, and over to you, Dr. Komal.
Thank you so much, Dr. Poonam. And on behalf of the ISOPAP Mumbai chapter, I welcome you all for this webinar. This is the second of our series on optimizing pregnancy care. And as we know, that from 7th of February to 14th of February is celebrated as a Congenital Heart Defect Awareness Week. And we know that the incidence of congenital heart defect may be 1 in 200 live birth. Yeah, but all over we see so many patients of congenital heart defects, and when detected early, then we can take a pediatric surgeon reference, or we can do something about the congenital heart defects. Some anomalies are life-threatening and has a very bad impact on the outcome, the neonatal outcome. So we need to detect it early, and heart defects usually are missed and detected late. And then we cross the legal age of the MTP termination. So we want to know how to prevent these heart defects, how to raise awareness on detecting early detection of these heart defects, and also how to know early screening strategies. So this webinar is focused on it. And to complete our obstetrics and gynec, we have a panel discussion to discuss about heart disease and pregnancy. So this webinar actually is by the TOG Science Integra team, and I thank Integra's who are supporting us for this awareness of birth defect in a 3-webinar series, and this is second of our series. And we at ISOPAB Mumbai chapter are very, very fortunate to have Dr. Suchitra Pandit as an able president, and with Dr. Suchitra Pandit as a president and Dr. Rajendra Nagargatti as a secretary, we have been conducting all these different programs with concept. And I welcome Dr. Suchitra Pandit, who is a consultant at Department of Obstetric Gynec at Surya Hospital, Mumbai, chairperson of AICC RCOG. She was a former, just an immediate past president of the organization ISOPAP, president of organization Gestosis 2016-21, president Foxy, past president of Foxy, ICOG, then even a FIGO Woman Awardee 2018, and a Foxy representative AOFOC. And she is a great teacher and having a vast teaching experience of more than 34 years, and have done immense work for upliftment of women and Kishori project and youth melas. So over to you, Dr. Suchitra Pandit, madam, to welcome our chief guest and guest of honor.
Thank you so much, Komal. First of all, I would like to extend a very warm welcome to all the viewers who have tuned in for this very important webinar. And as Komal said, through the Indian Society of Perinatology and Reproductive Biology, it is the neonate itself, because the Mumbai chapter has Raju Nagakat is the Mumbai chapter, both of them have really worked hard together to bring about this, this whole series of awareness into how to make optimizing the pregnancy outcomes. And today I'm very, very happy that for this particular program, we've got a very eminent personality who was the past president of Foxy and who has been the past head of the department of AIMS, Dr. Professor Alka Kriplani. Very, very happy to see her here. She has been not just the past president of Foxy, but also the president of the Gynecological Endocrine Society of India, then the Delhi Gynac Endoscopic Society, and AOGD, as well as the editor of the Asian Journal of OBGYN. And she's currently on the editorial board of 9 journals. She's a co-chair for the Menstrual Disorder Committee of FIGO, and she's got around 47 awards. And incidentally, we should have introduced her as Padma Shri Professor Dr. Alka Kriplani, and she's also the proud recipient of the BC Roy Award and, of course, the honorary of RCOG. She's got so many wonderful awards to her credit, and she's an excellent endoscopic surgeon and is currently practicing in the suburbs of Delhi. However, she's participated actively in all the Foxy workshops, imparting her knowledge and her creative skills. And I'm very, very happy to welcome Professor Padma Shri Dr. Alka Kriplani. And of course, before I invite her, I'd also like to introduce a very, very dear friend, Dr. Jayam Kannan. Dr. Jayam has been the Foxy Adolescent Health Committee awardee. She is also the Professor Emeritus of Tamil Nadu, the MGR Medical University, Managing Trustee of the Garbha Rakshagi Group of Institutions, Director of the GFC Fertility Center, Trichy and Chennai, and has been the Vice President of Foxy. And of course, in her capacities as President and a very active worker of Foxy, she also was a member of the Prevention of Violence Against Women Cell, as well as the Adolescent Committee. And what I would like to say is her work has been specially recognized by the RCOG, and she has received a medal to commemorate all her achievements. And of course, again, very proud achievement of hers is the President of India Medal for Outstanding Performance in MBBS medal, and for all the possible gold medals in the final MBBS. Stayed first in the MBBS University, the Best Book Medicine Award, and of course, she received the award that I had instituted in my parents' name for women's empowerment. So we are very, very proud that Jayam is associated with us, and with all her wonderful achievements, I welcome her as a guest of honor. So both Alka and Jayam, very, very dear friends, thank you for sparing the time and coming in as giving us your blessings. Thank you very much.
Thank you very much, Dr. Suchitra. What to say about Suchitra? I'm watching her for decades. A silent, continuous hard worker. See people come and go, and I'm watching Suchitra for decades, one or the other association, and she's always into academics. And what to say in the Foxy, she brought this concept of, taking youth along. Nobody thought of it, these youth melas, these Kishori programs. When Suchitra herself was a Kishori, since that time she is, for youngsters. Suchitra, you have amazing, persistence, perseverance. I salute you for that. What to say of this youngster Komal Chauhan, who has come for few years, working very, very hard for Foxy in all committees. And this association ISOPAR, this was started from Bihar, and now year after year people are, continuously working. And, endoscopy, IVF have lot of glamour. But let me tell you, these basic obstetrics, this high risk pregnancy, these are the topics which are of interest to majority of gynecs. And majority of patients, if you impart knowledge and training in these areas, which somehow, I won't say neglected, but now everybody is realizing these hypertensive disorders and all, they are a reason for so much of morbidity and mortality in the country. So again, I salute these people to take these topics, as main in ISOPAP, this Mumbai society nowadays, and this congenital heart disease, so common. Time and again, I see a baby is born with a defect, and if it is diagnosed in pregnancy, it's very important to send them to a proper center to deliver, because otherwise it is very difficult to shift the baby. And everybody is prepared, parents are prepared, doctors are prepared, pediatric surgeon is made available, and the outcome is totally different if we know beforehand. And if there is going to be a very major defect and it is nowadays detected before 20 weeks, then termination, I myself must have done so many terminations for these severe heart defects before 20 weeks of pregnancy. So I wish you people all the best, Mumbai society, which is so strong. But my dear friend Suchitra, who is a real flag bearer and for decades continuously working without break, let us enjoy this webinar. And the organizers, thank you everybody for the organization, and thank you for the invitation.
Thank you very much.
Thank you so much, Alka Madam, for those person and such a nice work. Thanks for being here. And Dr. Jayam Kanan is busy in a Foxy UNICEF Lakshya conference and will be joining and giving her pearls of wisdom and address at around 5:30. So we can now I ask Dr. Rajendra Nagargatti, Secretary of the Mumbai chapter of ISOPAP, to give his remarks at the inaugural. And Dr. Nagargatti is the chairperson of Foxy Midlife Management Committee of Foxy as well as AMOX, and an executive council member of MOGS, past president of AFG, joint treasurer, associate of medical consultant Mumbai, past president of IMA Meera Bhainder, and past president of Bhainder Medical Association, a consultant at Ashirwad Maternity and General Hospital, and also attached to Gokad Hospital, Bhimsen Joshi Municipal General Hospital. So, Dr. Nagargatti, over to you.
Thank you, Dr. Komal, for the kind words. It's really fortunate to be a secretary, a founder secretary for this association, which has been started by a dear friend, Dr. Suchitra Pandit, who was so very passionate about this ISOPAP and the perinatology, and she wanted to start this particular Mumbai chapter, and it was her persistence and her perseverance that has led us to this new chapter. And with a wonderful joint secretary like Dr. Komal, I think we are doing leaps and bounds in doing programs. So I once again congratulate Dr. Komal for doing such wonderful activity for this Mumbai chapter. And of course, with her efforts, and with the efforts of Dr. Suchitra, more and more people would come forward with programs. And today's topic is something which is, I think, something very, very different on the cardiac problems, both in the fetus and cardiac problems in the patient in the antenatal pregnancy. So we are discussing both the aspects. And even just now, before I came here, there was a patient in the consulting who had come with a 2D echo, fetal 2D echo report of a small ASD, and they were so very worried and anxious. So it's such a huge problem whenever they are faced with this particular congenital heart disease in the newborn. And therefore today's discussion is very, very apt, and we should definitely try to find ways and means of preventing these complications. And for that, we have a wonderful speaker in the form of Dr. Pooja Wazirani. And then, of course, we have a panel discussion on heart disease in pregnancy, which will throw light on how to manage these patients in the antenatal period. So, first of all, I would also like to welcome and say that how fortunate we are to have Dr. Alka Kriplani ma'am as a chief guest for this program, along with Dr. Jayam Kannan. She's such a huge name in Foxy and all over India. And as Dr. Suchitra Pandit ma'am said, she's got so many awards and she's so passionate about her work. So it was a real pleasure to have you here, ma'am, and to listen to your words of encouragement and blessing for the Mumbai chapter of the ISOPAB. So without much ado, I will just hand it over back to Dr. Komal for taking it forward. Thank you.
Thank you so much, Dr. Nagargatti. And I request you to please wait, because you're also chairing the much awaited talk by Dr. Pooja Vazirani. So I would like you to introduce Dr. Pooja Vazirani and welcome her for a talk on
Shailaja.
Yeah, and also Dr. Shailaja to join as a chairperson. So may I have the CV slide of Dr. Shailaja? And Dr. Shailaja Pinjala is an associate professor at AMC VSP, a secretary of Obstetrics and Gynecological Society of Visakhapatnam, organizing joint secretary of Yuva Foxy South Zone 2020, a fellow of ICOG, and has presented papers in state and national conference, 10 publication in Index Journal, a UG PG examiner, a faculty in state and national conferences with special interest in practical obstetrics and high-risk pregnancy. Welcome, Dr. Shailaja, to the ISOPAB Mumbai chapter. And it is very nice that you are joined us for this program. And I hand over to both the chairpersons, Dr. Rajendra Nagargatti and Dr. Shailaja, to welcome our first speaker and introduce and start the proceedings.
Thank you. Welcome, Dr. Shailaja ma'am, on behalf of the Mumbai chapter. And I would also like to afford a warm welcome to the entire faculty that we have today. Apart from Dr. Alka Kriplani madam, Dr. Jayam Kannan, Dr. Shailaja Pinjala, Dr. Pooja Vazirani, and then we have our very own Dr. Sujata Dalvi and Dr. Amay Purandare from Mumbai. And we have eminent panelists in the form of Dr. Arun Nayak, Dr. Suranjan Chakrabarti, Dr. Varsha Lahade, Dr. Danny Laliwala, Dr. Munjal Pandya, and Dr. Sureka Taide. So I afford a warm welcome to all of you for taking your time out of your busy schedule and joining us on this webinar. And I would now like to request Dr. Shailaja Pinjala madam to introduce our speaker for the day, Dr. Pooja Vazirani.
Good evening, everyone. First of all, I would like to thank the president of ISOPAB, Dr. Suchitra ma'am, and the secretary of ISOPAB, the Mumbai chapter, Rajendra Nagarkatti, and also Dr. Komal Chavan, the medical disorders of pregnancy chairperson, Foxy, and also the convener of this series. Thank you, ma'am, for giving me this opportunity. May I have the slide, please? Her CV. Dr. Pooja Vazirani is an MD DGO, DNB, and FCPS, and a fellow of the Fetal Medicine and Mediscans Chennai. And she's a fetal medicine consultant at Hirandani Hospital, high-risk and high-risk obstetric department, Surya Mother and Child Hospital. She's also presented various national conferences, presented various chapters, talks in national conferences, and a member of the Fetal Medicine Committee, Foxy. Over to you, Dr. Pooja Vazirani. Dr. Pooja Vazirani, she'll be talking on the role of folate in congenital heart defects and its early screening of heart diseases.
For the benefit of the viewers, Chairperson, I would just like to say that Pooja is a brilliant student from LTMG Science. She was my student. And, the way she has developed her skills as a fetal medicine consultant is amazing. And she becomes our consultant too, for referral of any problems. So, Pooja, we're very, very proud to have you here. And I'm sure you have so much of knowledge, and you train with one of the best fetal medicine persons in India. So over to you, and we're all eager to hear you.
Thank you, ma'am. Thank you, ISAPA Mumbai chapter, for this wonderful opportunity. It's really an honor, and I'm really grateful for it. So the topic for today is the role of folic acid in the prevention of congenital heart diseases and early screening. We should know that the incidence of cardiac diseases in fetuses or in the neonates, it's quite high, about 8 to 10 in 1,000 live births. But the overall incidence, if you take into subtle abnormalities, it will be about 50 in 1,000, which is really high. Therefore, prevention forms an important part of our clinical practice. And folic acid, a much talked about tablet or the medicine in the prevention of neural tube defects, have got an association to prevent congenital cardiac abnormalities also. And why was it so much an importance is that maternal folate insufficiency during early pregnancy is associated not only with anemia, but pregnancy complications and birth defects, out of which the cardiovascular and the neural tube defects form a major chunk. And a surprising fact is the role of folate during pregnancy was actually studied in Hindu Indian women, because maybe because of the low socioeconomic status at that time and nutritional deficiencies. The metabolism of folic acid in cardiovascular is basically dependent on the dietary folate, which helps to serve as a methyl donor. And the main area is the 5-methyl tetrahydrofolate enzyme reaction. That is, it helps to provide methyl groups to homocysteine that is converted to methionine and releasing tetrahydrofolate. And this is further required for nucleotide synthesis. Vitamin B12 is necessary for this transfer of methyl groups, and therefore folic acid along with vitamin B12 is now the victim of management or preventing these complications. The exact mechanism is actually not elucidated in the prevention of cardiac diseases. However, as I said, the methylene tetrahydrofolate reductase, that is MTFHR enzyme activity, may be involved. And therefore, women with these kind of genetic abnormalities or the gene mutations are high risk of having fetuses with congenital heart diseases. And definitely there is an association with homocysteine levels, MTFHR, and cardiac diseases in the fetuses. Now, individuals who have actually vitamin B12 deficiency, the folate is trapped in them, and therefore there is a combination of folic acid deficiency in women who are basically vitamin B12 deficient. So a combination of these two is now needed to prevent them. Women planning pregnancy or in the first trimester, we recommend, or the international bodies and the current data, or the randomized controlled trials definitely tell them to recommend folate containing supplements in order to prevent NTDs, that is the neural tube defects, which are the open one. There are RCTs for this, but however, we don't have randomized controlled trials on the dosage of folic acid in prevention of cardiovascular problems. However, the association is well proved. How this association came into play is that infants and children with congenital heart defects had high homocysteine levels and disorders in folate metabolism. Homocysteine levels were also high in mothers of infants with congenital heart diseases, and therefore maternal genotype for several folate metabolizing genes have shown associations with a child with cardiovascular problems. As I said, the optimal folate dose is not known. However, if folic acid or folate is proven to prevent cardiovascular diseases in the fetuses, then it's going to have a major impact on the public health, seeing the incidence that is about 50 to 70 per 1,000 if we calculate all the subtle cardiovascular problems also. And the search is on for additional nutrients that may prevent cardiovascular problems in fetuses along with folic acid. So this was a very good review in 2019 who said that women would benefit from 800 micrograms of supplementation of folate compared to 400 in those patients who have a starting RBC folate that is close or below the population mean, a very short time to pregnancy, that is a pregnancy interval of less than 2 months, poor compliance with supplements, and willingness to take these supplements before conception. Women with MTFHR gene mutations, especially recurrent abortions, thrombophilia, they do show a gene mutation with the MTFHR gene. Disadvantaged women, and they classify into low education, immigrants, and low income, and women with unplanned pregnancies, and women who start supplementation after a positive pregnancy screening test. And therefore, they said 800 would be better in this woman rather than 400, which is usually given. So the keynotes to folate in cardiovascular is that current data support that folic acid is the active ingredient involved in fetal cardiac embryogenesis. There is good evidence that folate supplementation may have a protective effect against severe types of congenital heart diseases. However, there are no randomized trials to support that doses of folic acid in milligrams will be more effective than the currently recommended 400 to 800 micrograms, taken at least 2 to 3 months prior to conception until the end of first trimester. So we still follow the microgram dosage of folic acid. That is the message we want to give, rather than supplementing them with higher milligram of folic acid, which can cause some amount of disturbance as proven by small studies in the past. So when we talk about prevention of heart diseases, definitely we need to diagnose them as early as possible to create less trauma in the mother, as well as appropriate counseling at the right time. So in the year 2006, the Ultrasound Obstetric Gynecology Journal provided us the International Society of Ultrasound in OBGYN, the cardiac screening, the fetus guidelines, basic and extended. It further updated the guidelines in the year 2013, and now we have a proper guideline for fetal cardiac examination, which should be followed by all who see the fetuses at whatever gestation they come for. They said that screening of fetal heart should not be only for those people who are high risk, but actually the low risk population, because they found that cardiac diseases were actually more found in low risk who were undiagnosed and had a surprise after delivery. So screening for fetal heart is for the entire population. It should be a part of your target scan between 20 to 22 weeks or 18 to 20 weeks. And definitely the fetus should be referred for a detailed fetal echocardiography whenever there is a suspicion. They said that the basic cardiac screening relies on the 4-chamber, but the imaging of the outflow tracts definitely increase the sensitivity and the diagnostic rate of fetal cardiac problems. And therefore, the basic and extended views are a compulsory thing when you want to screen the fetal heart. There are several indications, but what I want to highlight, fetal indications, which are early in pregnancy, like the increased nuchal translucency, the abnormal ductus venosus waveform, tricuspid regurgitation, and apart from that, the maternal indications. So this actually is an important part of your first screening when you see the fetus. Who should do a fetal echocardiogram? Anyone who's well trained with a fetal heart definitely should do it with appropriate skills and follow the guidelines. Initially, we knew that cardiac screening, when we were doing our masters or even in the OBGYN practice now, they feel that the heart is very well seen between the 18 to 22 weeks. There is no doubt about it. That's the best time to see the fetal heart and diagnose major cardiac abnormalities. But the paradigm has completely shifted to the 11 to 14 week scan. Identifying the high-risk fetus from a low-risk fetus in a low-risk mother is definitely now the standard of care, which is between 11 to 13 plus 6 weeks. Now, this relies on important ultrasound markers, and the most important one is the nuchal translucency, which is actually a marvelous discovery of Professor Kipros, because it opens the gateway to the structural abnormalities of the fetuses and genetic abnormalities, and where cardiovascular thing forms a major chunk. Why? Because an increased nuchal is not only associated with Down syndrome or other common aneuploidies, but also forms a major part of cardiac abnormalities, which are talked today, and apart from many other benefits. An increased nuchal is actually defined as a nuchal translucency above the 95th centile for the respective CRL, whether it has septations or not. And this has to be taken into mind, because the higher the nuchal from 3.5 mm, you will see the larger percentage of having fetal abnormalities, and again cardiovascular form a major chunk in these abnormalities with increased nuchal. The next marker in the first trimester for screening for fetal cardiac abnormalities is the ductus venosus, which is a small vessel connecting the portal vein to the IVC. And this, when selected for having a Doppler evaluation, a forward flow, that is the A wave, should be positive, which is a good sign. A reversal of ductus venosus is not only an indicator for common aneuploidies like Downs, trisomy 18, 13, and Turner's, but definitely has increased risk of cardiac defects. And this was very well proved in the year 2011 by Professor Kipros. He said that fetuses with major cardiac defects not only have an abnormal DV in fetuses with increased nuchal, but also fetuses with normal nuchal translucency. Because of the cardiac abnormality, you could see a reversal in the ductus venosus. In monoclonic twins, which are high-risk twins for not only a complication like TTTS, but also cardiac abnormalities, DV reversal plays a very important role in triaging these fetuses into high risk or low risk. The next marker is the tricuspid regurgitation, which is again taken at the four-chamber view with a gait of 3 mm and a velocity of more than 60 centimeters per second in your first trimester is known as tricuspid regurgitation, and in the presence of a normal nuchal and a normal ductus again forms an important part to screen the heart at 11 to 13 plus 6 weeks. Again, it has importance in common aneuploidies, but has a very high association with chromosomally normal and abnormal babies with cardiac defects. This is why, because the increased preload, that is cardiac muscle stiffness, and increased afterload, which is seen in with increased placental resistance between the 11 to 13 plus 6 week scan. Any doubt like an increased nuchal, DV reversal, or tricuspid regurgitation, you need to see the fetal heart in detail. Why? Because they show a rising percentage of fetal cardiac abnormalities whenever tricuspid regurgitation is present. So the 11 to 13 plus 6 week scan is now the scan for triaging low risk babies into high risk babies from low risk mothers or high risk mothers. And definitely then the important 18 to 20 week scan is a must for all. So the fetal heart at 11 to 13 weeks can be done by transabdominal as well as transvaginal screening. A CRL of minimum of 45 mm is needed. However, the best screening will be done if the CRL is between 60 to 80 mm, that is around 12 to 14 weeks. You have to assess the situs, so you know the situs abnormalities. The B mode will tell you about the four-chamber and arches, and the color flow is a must in the 11 to 13 week scan for cardiac imaging. That is, you'll be demonstrating the four-chamber and arches with the normal flow. So this is the first trimester video where if you zoom up, you have to follow all the B mode applications as you follow in 18 to 20 weeks. And what you need to do is see the four-chamber, put the color, and see the flows. You have two inflows, which are seen with two red, and the two outflows, these are the arches. If you document these two views, you're actually screening the heart for major complex cardiac abnormalities right at 18 to 13 plus 6 weeks scan. So in the B mode, you have to document the four-chamber of the heart, very well seen, beyond the CRL of 60, as I said. You can in fact see the crux over here. You can see the four-chamber, and if you have the eye, you will see the pulmonary venous connections as early as 11 to 13 plus 6 weeks. This is a transvaginal scan. Again, you will be seeing the interventricular septum ruling out larger atrioventricular septal defects, which are again form a major chunk of cardiac abnormalities in Downs babies. So color is a must. So you have B mode and color, which forms an integral part of screening of these fetuses. And if you are an expert, if your hands are good, you may actually see the left ventricular outflow tract in these fetuses right at 11 to 14 weeks. Not only the left ventricular outflow tract, which is the L-shaped thing, you may also document the branching of the pulmonary arteries. Therefore, the atrioventricular connections and the ventricular arterial connections will be well established. So what are the abnormalities which we detect in the 11 to 14 week scan? These are four-chamber abnormalities in the grayscale, dextrocardia, the situs abnormalities, severe tricuspid regurgitation, single ventricle, a large atrioventricular septal defect, hypoplastic left heart syndrome, ventricular disproportion, mitral or tricuspid aprasia. And this is actually the hallmark of the today's era of 11 to 14 weeks, where all these were actually diagnosed at 24 weeks, when we were supposedly of the impression that fetal echo should be performed at 24 weeks. And this is changing the entire outlook to see the fetuses in today's era. In fact, the three-vessel trachea view, that is the outflow tract views which I have shown, you can actually diagnose discrepant vessel size, reversal of flowing aorta or the pulmonary artery, a large aorta, and a to and fro flow in the pulmonary artery or aorta, interrupted aortic arch, right-sided aortic arch, and aberrant right subclavian artery. This was a case at 12 weeks. The nuchal was absolutely fine, but the four-chamber also was normal. We could see a single OT, that is the outflow tract, in the three-vessel trachea view. This was followed up at 16 weeks, where the baby showed, branch pulmonary artery, very narrow, so it was a double outlet right ventricle with pulmonary atresia at 16 weeks, and it was turned out to be a Down syndrome at that time. A second case, low risk primary gravida, 32 years, enlarged nuchal translucency, single umbilical artery, and override of the aorta. This was again between 12 to 13 weeks. Definitely genetic abnormality, high association, and was positive for trisomy 80. Third case, increased nuchal, reversal of flow in ductus, and mild pleural effusion with hyperplastic left-sided heart. And this was turned out to be Turner syndrome. Patient opted for termination of pregnancy. This was another case where we had the four-chamber view, which was fine, but the arch view, that is the three-vessel trachea view, showed parallel outflow tracts, and this was a transposition of great arteries, diagnosed at 12 weeks, confirmed at 16 weeks. There are common arterial trunk associations also. This is a transvaginal scan of a fetus around 74 mm, so you can actually see the clarity, which is very high. There's a large atrioventricular septal defect. It had a common aorta override and definitely had MAPCAS, that is pulmonary artery, the branch pulmonary artery arising from the aorta. So definitely very high chance of cardiac abnormalities, 22q microdeletion, and extra cardiac abnormalities. The whole idea is to show that the 11 to 14 week scan can give you a lot of information as regards as the four-chamber normalcy, and not only that, detect complex cardiac abnormalities and outflow tract abnormalities. This was a case of tetralogy of Fallot with absent pulmonary valve syndrome. You can see a sudden to fro changing of color, that is red, blue, red, blue. This is a retrograde and a forward flow in the pulmonary artery, which is a hallmark for absent pulmonary valve syndrome. Again, quite complex problems can cause hydrops if not treated, and definitely high association with 22q microdeletions and other common chromosomal abnormalities. To summarize, that the early screening of fetal heart is possible. Training, however, is required. The 11 to 14 week scan, along with your nuchal, ductus venosus, tricuspid regurgitation, and the B mode and color flows will help in early identification, proper counseling, and appropriate application of genetic test. A definite review at 16 weeks is needed once a cardiac defect is identified. When we identify a cardiac defect at the 11 to 13 weeks in the presence of other markers being normal, we don't label the disease. We say it's a single outflow tract, we say it's a single ventricle, we say it's an AVSD. But however, if the patient is continuing and the genetic tests are normal, despite that, we need to see the heart again at 16 weeks. And that's important to confirm the diagnosis and hemodynamics of the heart change. So a better view is needed at 16 weeks. And this is a very, very important thing. We don't terminate or we don't label cardiac diseases at 11 to 14 weeks. We give our findings, review at 16 weeks, and definitely all other indications for fetal echocardiography, as far whatever the maternal and fetal indications, go hand in hand with the early screening also. Today, stick modalities are also possible in the hands of expert. So we get a multi-planar imaging of the cardiac at the 11 to 14 weeks. And it's really it's a delight to see how the experts in fetal echocardiography actually do the stick modalities in fetuses as small as 5 centimeters. So the paradigm has really changed, and for the betterment for our society. And the last word is continuous training of healthcare professionals helps in improving the effectiveness of a screening program. Thank you so much.
Thank you for that wonderful insight into cardiac problems in the fetus and how to diagnose them as early as possible, so that the initial concept of waiting till 22-24 weeks for seeing a full proper cardiac shadow, it's no longer valid now? So it's
No.
okay.
It's no longer valid because I think we all have shifted to the 11 to 14 weeks screening test for Downs, and screening for heart forms a part of that, and definitely gives you insight about major cardiac abnormalities. I mean, we don't have to wait for a AVSD till 18, 19 weeks, or we don't have to wait for a hypoplastic left heart. All these major abnormalities, which have poor prognosis, definitely can be diagnosed at 12 to 14 weeks or 11 to 13 weeks. And then the subtle abnormalities like discrepant ventricles, discrepant great vessels, definitely they need a review at 16 weeks for confirmation and applying proper prenatal diagnostic testing. Like the 22q microdeletion forms an important part of your cardiac genetic testing. So that with a lot of good genetics tests available, this is more possible and definitely effective counseling and early counseling.
Dr. Pooja, then so at 16 weeks, if it is, you say that it is, there is a congenital heart disease, then we can go for termination or anything like that. Now, we not wait until TIFA scan, that is at 22
No, ma'am. If your cardiac scanning shows a proper complex cardiac abnormality at 16 weeks, which has poor prognosis, definitely can be counseled at 16 weeks. We don't need to wait for the TIFA scan.
So large dose of folate, which is supplemented, is it necessary to only supplement before the, peri-conception? You said 2 months before conception.
Yeah.
So if patients usually don't come at that time.
That's fine. So that's what, if the patient is coming for a pre-pregnancy counseling, which nowadays many people are aware of that, because if you see the trend is changed, we have a lot of women who are smoking, we have a lot of women who are having alcohol. So the questionnaire of Indian scenario has actually changed. We never used to ask these questions in our MD. I mean, we used to feel, no, she might get offended, but now it's not the case. So many people, the awareness is increased. So if they come for pre-pregnancy counseling, they have an excellent window to prevent it. However, if they're coming to you for the first visit, start at that time. That is a routine practice. And I think everyone, all of y'all will be a better word in the obstetric care of.
Larger dose you recommend?
800 micrograms. If she's, ma'am, actually I cannot hear you. The volume is a bit low.
Yeah, the dose
is 800 micrograms of the proper, the folic acid, or it is of the tetra. I mean, it's the active.
No. Folic acid 800 micrograms is good enough. Now, if she's from a good family, good nutrition, 400 is also quite good. What we usually give.
No, but the standard preparations, the age-old folvite, they contain 5 milligrams. So
that's what the new data is saying, that we are actually overdosing them.
Okay, so even if the basic folic acid also just 800 micrograms is
along with vitamin B12. Along with vitamin B12, it has to go hand in hand.
So then, if it's the what do you call the quadrifolate which has now come up, in that case, then I think that also is being provided in 500 micrograms or 800 micrograms. So, what is your opinion about this new molecule, the active form which is available?
If the active form is available with 800, that is the most available form, I think, then for absorption. I'm sorry, I won't be a better person in the latest obstetric medicine.
Okay.
Like you will be a bit more, but the crux lies, how much do you give? So if you give 800, that's well good. Some people do give 5 milligram if there is previous neural tube defects. I can understand, because the neural tube defects, the recommendation was 5 milligram of folic acid along with 10 micrograms of vitamin B12. But again, 5 milligram, what they are saying is actually a high dose. We don't require such high doses.
But is there any toxicity with a high dose? I mean, like, because this 5 milligram.
There is, some papers have shown. Some papers have shown, but I don't recollect. But there are randomized trials which have shown a bit of a risk factor if you give large amount of folate.
Okay. Any?
One question.
Ma'am, you could,
Yeah, in diabetic patients, I mean, of course, we'll be doing the nuchal scan and the anomaly scan, but usual recommendation used to be to do an echocardiography at about 22 to 24 weeks. So in diabetic patients, should we still go ahead, despite these scans, okay, should we still go ahead and ask for a fetal echocardiography at 22 to 24 weeks?
What I would say, ma'am, if you're doing the diabetic scan, the first scan is 11 to 14 weeks. We are then going to see a TIFA.
Yes.
If you send to any person, be it a sonologist or a fetal medicine expert, we do fetal echo for everyone. Because the ISOG guidelines, our international guidelines, have 5 screening views, which actually covers the fetal echo along with color flows. Additionally, in obese women, we from our side only, if you are having some optimal view at your 18 to 20 weeks, we call them at 24 weeks for a reconfirmation. However, if anything has to be picked up, it will be picked up earlier as well, like between the 18 to 20. There is no need for an extra fetal echo for anyone. However, in diabetics and obesity, because they might go hand in hand, we would like to see the fetuses as a second shot at 24 for other things. However, evolving problems, we also are very careful. Evolving problems like evolving coact or evolving pulmonary stenosis will not be picked up at the first spot in the TIFA. So anyway, these women will be following up for the interval growth scan. So from our side, the protocol is to see the heart at any time the mother comes to us, be it at 37 weeks, be it at 32 weeks. So we do diagnose late trimester gestational cardiac issues also, which will help in managing and delivering at the right spot. So if she's obese, then yes, a relook at 24 weeks is justified. But if you're sure that you've done it from a person who's doing the fetal heart correctly, then I don't think an extra fetal echo is required.
Yes, Jayam, madam.
Yeah, after this 24 weeks accepted by the court, in many cases, all over Tamil Nadu, we have started doing a scan at 24, 25 weeks for the fetal echocardiography, which we have made it mandatory in all our patients, so that they don't come and tell us after we find a membranous VSD, when it persists after delivery, they come and demand us why you did not do it. So now we have made our skin very safe in Tamil Nadu.
That's nice. That's nice. Of course, 24 weeks, if the court has imparted, we are happy. But actually, we would have been happier that there is no bar, because fetal evolving problems are really quite dicey, can come up at any time in the later gestation. So I would say then why spare those women with the trauma when they have problems at the later gestation. But that's excellent that in your area 24 weeks has come. It's really good, really good.
Yeah, it was a very fantastic talk, Pooja, and I think so many questions are overflowing, most of which you have actually covered in your talk. But there is a question from Dr. Kamal Patil from Belgavi, and she's asking, what is the risk of congenital cardiac disease if one child is affected or else if one of the parent is affected? So is there any risk factor for this?
Yes, it's about 3 to 5% more if your sibling is affected.
Oh.
Yes. So, and if the mother also is affected, definitely there is a high risk of congenital heart disease in the fetuses. But usually we have never, it's very, very less. The maternal cardiac problem does not affect the fetal to that extent like the sibling, because you have autosomal recessive problems and autosomal dominant. However, the first sibling, if having a cardiovascular problem, the second is 3 to 5% more than your baseline risk.
And that there is Dr. Anubhuti from Rewari. She's asking that if there is a coarctation of aorta or a hypoplastic left heart and it is identified in the early scan by 16 weeks, and then if they both are willing, so should they go ahead with termination, or that is the only option, or they can continue?
Hypoplastic left heart is a severe form of a small heart on the left side. Now that can come with a retrograde flow in the aorta, and that's a sure shot. It's not a good prognosis, because left ventricle is actually a dominant ventricle required post-birth. However, if you say coarctation, now that's got a good amount of, very, very good therapy or a treatment available post-birth. So if it's a coarctation of aorta, definitely I will suggest a prenatal diagnosis to rule out Turner's in such cases. And definitely if the flows are good, if the vessel size, it all depends on the vessel size also, along in hand with the consultation with the pediatric cardiologist, we have continued coax and delivered them and treated them post-birth. So coarctation per se is not a indication for a straightaway termination if the parents are willing to treat the baby post-birth. However, hypoplastic left heart, which is a very severe form of hypoplasia, that is justifiable if they don't want to continue. However, the take-home message is finally what the parents feel comfortable for them. That should be advised rather than a directive counseling.
Yes. So well put up, Dr. Pooja. Thanks. There are so many other questions. I think most of it you have repeated, like role of folate in congenital heart defects and how to early screen neural defects. So I think you have covered it at all. So I think it was a fantastic talk. And Dr. Anubhuti is again connecting. Is it legal to put these isolated cardiac anomalies for MTP under MTP Act?
Cardiac abnormalities form a part of fetal abnormalities. Cardiac abnormalities are major abnormalities. Okay, so if you have a congenital cardiac major abnormality, definitely before 20 weeks can form a part of your medical termination of pregnancy. Yeah, I don't know if your seniors will agree to that, but yes, that's the way it is. Like, we can't expect a mother to have a hypoplastic left heart and she wants to discontinue. We cannot put in MTP. Of course, you can, because it is a complex cardiac problem. Yes.
Okay. Thank you. Thank you so much. And it was a real informative, wonderful, excellent talk. And so many queries and doubts also you have answered. It was really great listening to you, Dr. Pooja. Thank you so much. And I also thank Dr. Nagarkatti and Dr. Shailaja Pinjala. You have chaired the sessions wonderfully. And that brings to the end of the first talk. And I'm so happy to have Dr. Jayam Kannan here with us, and as a guest of honor for today's program. And we all know Jayam Kannan madam so well, and Madam Suchitra madam has introduced her so well. And we are very, very happy and fortunate that you have joined in time for the webinar. And I would like to invite you to address the audience and give your message to all the participants for today's program.
Good evening to all of you and my dear friends from ISOBAB. I have been connected with ISOBAB thanks to Dr. Suchitra and Nagarkatti. I have attended the meetings at Mumbai, Pune, and every place. Today, I could join a little late. Everybody knows well it is due to the Foxy meeting which I had to attend. This conference of ISOBAB with this cardiac problem, which Dr. Pooja has elegantly and excitingly has put it up, is so great. Actually, I would have been a fetal cardiography ultrasonographer, but for my grandson who was born on the day when I was attending the conference at Chicago 12 years ago, where I had to leave the conference and come back. That was the way I left my touch with the cardiotocography. Now, coming to this conference, which has been excellently organized by great people like Suchitra and Nagarkatti, and with Komal Chavan, who is so close to me. Pooja has given a very excellent talk. Now, all of us are waiting for Amia and Sujata to have a great panel on heart disease in pregnancy, which is an upcoming topic in the Western countries, not far away from India, in the next decade to come. Even though we now have hemorrhage and hypertension as causes of maternal mortality, we are not far away from heart disease complicating pregnancy to be there as a cause of death. And with Dr. Arun Nayak, Suranjan, my dear friend Varsha, Dani, Munjal, and Sureka as a panelist, I am really waiting to hear an exciting panel from Amia and Sujata. Thank you very much for this opportunity. Have a great time. Learn more about heart disease, about which we are all so scared. And we think the minute we see a heart disease, the patient should be immediately shifted to a cardiologist care. Mm-hmm. We have problems in which we do have our obstetric role to be played, even though the patient is being seen by them. To give you a small example, 30 years ago, I had a Fallow's acyanotic, which could not be managed. She had 6 abortions terminated. She came to me for the 7th one. She was given 10 years lifetime up to 35 years. She was 32 years. I told her, you continue the pregnancy. If you die as a pregnant woman, they will consider you as a big Devi. Otherwise, you die at 35 years as an ordinary woman. She accepted. She was put in an intensive coronary care unit. She was delivered normally. And now the child is 25 years old. The mother is also alive. What more can I say about heart disease in pregnancy? So have a great time, listen, give respect to the patient, and go with the patient. You will reap success when we counsel her adequately. Thank you very much for this opportunity.
Thank you very much, Jayam, for coming from the.
Madam.
Thank you for being there for today's program. No, I know you were busy with you and Munjal both were busy with the UNICEF program, but I'm glad that you could make it here.
Suchitra can come out. Can Munjal and Jayam can come out of it? No, Suchitra. That is also there, you know, because we are representing down south. We have to be there in that.
Absolutely.
Have a great time, Amia. Go ahead with your panel with Sujata. All the best.
Thank you, Jayam madam, for joining and giving your blessings to this program. Thank you so much.
Thank you, ma'am. Thank you, ma'am.
Requesting Dr. Komal to please go
I
ahead.
just had lost connection. I've just joined back. Thank you so much, Jayam madam, and it was real great pleasure to have you. And now we start with the much awaited panel discussion on heart disease in pregnancy. And I call upon the moderators, Dr. Sujata Darvi and Dr. Amay Purandare, and the esteemed panelists, Dr. Arun Nayak, Dr. Surekha Taide, Dr. Surjan Chakrabarti, Dr. Dani Laliwala, Dr. Munjal Pandya. Dr. Sujata Darvi, as we all know, as a consultant obstetrician and gynecologist in Mumbai, practicing in South Mumbai at Global, Sefi, Bhatia, St. Elizabeth, Rukmini lying in Jain Group of Hospital, an honorary clinical associate at Navroji Wadia Maternity and Jagjeevan Ram Railway Hospital. She's a real hard-working member of the managing committee of the Mumbai Obstetrics and Gynec Society for the last 15 years and very, very actively involved in all the programs of MOGS. Also the assistant editor of JOGI and the first joint secretary AMOGS, that is Association of Maharashtra Obstetrics and Gynec Society. Welcome, Dr. Sujata Darvi. I also would invite Dr. Amay Purandare, and Dr. Amay Purandare is consulting obstetrician and gynecologist at Purandare Hospital, KJ Somaya Medical College, Sir HN Reliance, Bhatia, Masina, and Mumbai Police Hospital. He was the Joint Secretary of FOXI 2019, and he has done wonderful work as a Joint Secretary. Chairperson of the Food, Medical, and Surgical Equipment Committee 2015-17, Assistant Administrator of FOXI Manyata Project on Quality Care in Safe Childbirth. Is also the managing committee member of the Mumbai Obstetrics Gynec Society and also the mentor for the Youth Council, honorary secretary of AMOGS, zonal coordinator, and the state coordinator for AMOGS. Is actively involved in the AMOGS organization, peer reviewer of the Jogi Journal, numerous awards and so many applauds to his credit. Welcome, Dr. Amay. And I hand over to the moderator to welcome the panelists and start the panel.
Thank you, Komal, for those kind words. Can the organizers please allow me to share the screen so that we start the panel right away? Over to you, Dr. Sujata.
Yeah, so at an outset, I would like to thank the organizers, especially Mumbai chapter of ISOBAP, for giving me and Dr. Amaya Purandare this opportunity to have this panel on heart disease in pregnancy. I would also like to thank the ISOBAP President, Dr. Suchitra Pandit, ISOBAP Secretary, Dr. Raju Nagarkati, and Chief Convener, Dr. Komal Chavan. Would also like to express my gratitude to our Chief Guest, Padma Shri, Dr.
Alka Kriplani.
Dr. Alka Kriplani, and a very nice and graceful message from Dr. Jayam Kanan before we start off with our panel. So I would like to invite our panelists. First panelist is Dr. Arun Nayak. Amaya, next. Yeah, Dr. Arun Nayak is a professor and head of the Department of LTMC and LTMG Sion Hospital, Mumbai. He was the president of Mumbai Obstetric and Gynec Society in 2015 and 16. He was a secretary. He is currently the secretary of AMOGS. He is a visiting clinical fellowship at Chungam University, Korea. He is a joint assistant editor of JOGI, that is a Journal of Obstetrics and Gynec of India. He is a winner of various awards like Foxy Korean Award, Hargobind Medical Fellowship for Overseas Training, and winner of Young Scientist Award by Mumbai OBGYN Society. He's got a special training in laparoscopy and SUS surgery at Korea, and his special interests are in stress urinary incontinence and non-descent vaginal hysterectomy. Our next panelist. Next one, please. Yeah, our next panelist is Dr. Suranjan Chakrabarti. He is a visitant consultant obstetrician and gynecologist at Amri Hospital and Mission of Mercy Hospital, Calcutta. He is a chairperson of Medical Disorder Committee of Bengal Obstetrics and Gynec Society. He was a chairperson of Adolescent Subcommittee of Bengal Obstetric and Gynec Society. He's been a managing committee member of Bengal Obstetric Gynec Society from 2012 to 2021. He's been a vice president of ISAR Bengal, and he's been a joint secretary of ICE, that is International Conference of Endometriosis in Jaipur. Our next panelist is Dr. Varsha Lahade. She has been a director of Prag Hospital, Nasik. She has been working in public health since last 22 years. She is a gynecological laparoscopic surgeon. Her keen interest is high-risk pregnancy. She has published many national and international papers, and she has also got Sri Shakti Award. Next panel. Our next panelist is Dr. Danny Laliwala. She's a consultant and obstetrician and gynecologist since 2003 at Jaslok Hospital, Breach Candy Hospital, Masina Hospital, and Wokat Hospital, Mumbai. And his keen interest is high-risk obstetrics and infertility. Next one. Our next panelist is Dr. Munjal Pandya. He is an assistant professor at AMC MET College, Ahmedabad, Gujarat. He is a joint secretary of Ahmedabad Obstetrics and Gynec Society for the current year. He has received Dr. Shirish Daftari Young Talent Award from Ahmedabad Obstetric Gynec Society for the year 2017 and 18. He has co-edited a book on male infertility. He's published many papers and chapters, and he has various hobbies apart from whatever curriculum that we have it. And our next panelist is Dr. Surekha Taide. She is a member of IAEC Committee and Family Welfare Committee of FOXY. She is an ex-member of Study of Female Breast Committee of FOXY. She is a national faculty in numerous conferences of FOXY and AICOG over last 10 years. She has been past secretary of Sevagram Varda OBGYN Society and past president of Sevagram Varda OBGYN Society. And she has been co-leader of Maternal Near Miss Project of FOXY and AVNI and co-leader of Maternal Death Review Project of FOXY and AVNI. And she has contributed in developing content as faculty of online contraceptive course as such. So before we start off with a regular panel, I would like Dr. Ameya to have some introductory remarks of the panel, please.
So like Dr. Jayam Kannan said, that every heart disease in pregnancy is a challenge. But as obstetricians, we always know that challenges are what makes life interesting, and overcoming them is what makes life meaningful. And I think as obstetricians in our obstetric careers, we have realized that every heart disease in pregnancy has a lesson to tell us, which we must learn so that we give the best outcome to the mother and child. Over to you, Dr. Sujata, for the part of the panel.
Thank you so much. So we will be discussing heart disease in pregnancy with some case-based scenario that we have encountered in our practice over last few years as such. So I would like to start off with Dr. Arun Naik. What would be the incidence of heart disease in pregnancy in the that you encounter in your practice, and is there any difference between developing countries and developed countries? Dr. Arun Naik, please.
Yeah, at the outset, let me thank ISOPAB Mumbai chapter for inviting us to participate in this webinar. Sujata, what's the incidence of heart disease? It's around 1 to 2%, I would say. But also, if the incidence is rising, in recent past, we have started getting the graph of heart disease in pregnancy is on rise. because you will remember about 25-30 years ago when we were residents, we used to see heart diseases which are mainly the congenital type of heart diseases. But nowadays we are also seeing more and more heart diseases which are like cardiomyopathies, peripartum cardiomyopathy, as well as it's not uncommon to have a woman who is having even ischemic diseases during pregnancy, because many times the patient is elderly. We are seeing women who are getting pregnant even at the age of around 35, 36 and 40s. So we are also seeing nowadays the ischemic heart diseases sometimes, patients coming with history of ischemic heart disease and becoming pregnant.
Fine,
So
fine. So we have
the
varieties of,
graph is
sorry.
changing.
Yeah. So
Yes,
we
the
have
graph is
varieties of
changing
patients.
compared to the developed nations and our country. I think slowly we are catching up with the Western countries, and we are also seeing like how they used to see these acquired heart diseases a couple of years ago.
And what about the congenital heart disease where they've undergone some sort of a surgery, repair is done, and the patients come to you with a pregnancy? Isn't that
Yes, that's what
incidence
I
little
said.
more? Yeah,
Yes, congenital heart diseases, once upon a time, the complications associated with cardiac surgeries were so high that we never used to see many patients coming up with the pregnancies. But with
correct.
advances in medicines and surgical techniques, we are seeing more and more women with congenital heart disease which have been operated. We are seeing patients with valve replacements, balloon valvotomy, and a lot of these patients are coming with pregnancies. So pregnancy uh, uh, has become relatively safer nowadays, even in
Correct.
patients who have undergone cardiac surgery in the past.
Right. So that's a change in the scenario so far as heart disease and pregnancy is concerned. I would like to ask Dr. Surekha, what would be the effect of pregnancy on the heart disease? Patient already has a heart disease, she is pregnant. What would be the likely effect of pregnancy on the heart disease? Dr. Surekha.
So as we see, the cardiac status of the patient is going to worsen with pregnancy, because pregnancy itself has a lot amount of effects like increase in the stroke volume, then decrease in the peripheral vascular resistance, and you would also see that any kind of heart disease which is existing in the patient is going to worsen. There are more chances of CCF, more chances of pectoral endocarditis, pulmonary embolism, and even simple ailments like fever or any infection, anemia, if the patient is having, then
That
it's
would
going
get
to worsen the,
exaggerated.
yeah,
That's
it's going to
yeah,
be exaggerated.
fine,
So
fine.
as soon as the pregnancy is diagnosed, even at 6 weeks, you would find that the cardiac output is going to increase.
Fine.
Maximum it is around 30 to 30
Yeah, so that will
2
just
weeks,
deal it
and
little
that would
later, Dr.
increase.
Surekha. Yeah, that I'll just deal it with
Chances of
later.
preterm delivery, abortions,
That's
and
the yeah,
yeah.
that's the yeah. I want to ask Dr. Danny, what is the effect of heart disease on pregnancy? We discuss on pregnancy on heart disease, the other way around, Danny. What's the effect of heart disease on pregnancy?
So there
Dr.
are
Danny?
there are chances of missed abortions in these patients. Even the NTP rates may increase if we are diagnose them. They are like many women are scared to continue pregnancy till term because they may have deleterious effects. So the chances of MTPs can also increase. These patients may go into preterm labor. They may have restricted growth and IUFTs. Congenital heart disease patients, if a woman has a heart disease, then there are chances that the fetus may also develop a congenital heart disease. As far as around 2 to 3% are seen in them.
Fine. So these are the changes or these are the effect of heart disease. So wherever it is possible, women with pre-existing cardiac lesion should be counseled well in advance about the risk of pregnancy. So whenever women comes to you for the first time, you should counsel the woman and should try and discuss everything into details. I would like to ask Dr. Suranjan, what are the cardiovascular changes that usually occur during pregnancy? Dr. Suranjan, please, in terms of cardiac output, in terms of stroke volume, in terms of pulse rate, in terms of blood pressure?
First, I must congratulate uh, Dr. Komal and the ISOBAR Mumbai to give me the opportunity to be with you in this seminar. Now regarding your question, the hemodynamic changes of the during pregnancy on the heart. There is a increase as the pregnancy advances. There is the blood volume increases, cardiac output also increases, heart rate also increases. Is from the normal status to the blood volume increases up to 40 to 50%. As it is the second trimester and is the peak volume is 28 to 32 weeks, the second trimester, the early third trimester. And heart rate increases by 10 to 15 beats. Around, if it is a 70 is the normal rate, it will be 80 to 90. And the cardiac output by 50% above the baseline level.
Right.
And additional, if there is a during the labor, cardiac output is much more above of that. And initially, it all depends on the changing in the postpartum also. It affected during the early due to the preload. After the delivery is a cardiac overload due to the reversal blood volume. And regarding the blood pressure, it is a mid-trimester fall of the blood pressure. It will be by around 10 mRate. And then that stroke volume also increased. It was included the first and second trimester slightly in the third. It is a deep downward trend. Maybe you can content. And similarly, the systemic vascular resistance, it will be due to the effect of the estrogen, all the hormonal effect of other hormones. It will be switch from vascular resistance will be goes down. So peripheral vascular resistance goes down. Therefore, vasodilatory effects will be there.
Okay, fine. So I just want, I want to ask Dr. Varsha, what are the changes that take place during pregnancy, during labor, and postpartum, so far as cardiac output is concerned? And Dr. Varsha?
I guess she's not there, madam. She's
okay,
in
fine.
OT.
I could ask Dr. Munjal. Dr. Munjal, please.
Yes, ma'am. Actually, with regards to cardiac output, it increases during labor. It increases suddenly because of immediately after a baby, the extravascular, the interspace, the fluid in the interstitial space shifts to intravascular volume. That leads to sudden increase in cardiac output, and it is like almost 20 to 30% additional to what it has been during full term. So that is something which we need to keep in mind, because in case of specifically anemia, where there is anyway hyperdynamic circulation, and as we discussed previously, that if addition of infection is there, this particular rise in cardiac output, sudden rise in cardiac output will lead to cardiac failure. And so we need to keep in mind this particular change with regards to cardiac output.
That's right. And what about throughout antenatal? Any particular period that you have to be little more careful, that you would ask the patient to come little more often or report to you immediately? So you have to keep that in. So what period in the antenatal that you need to be little more careful?
So as previously said, from 6 weeks onwards, there is rise in plasma volume as well as RBC volume. With regards to this particular rise, it does stop at around 32 weeks, 30 to 32 weeks, where there is 50% as regards to non-pregnant state. So we will call this particular patient, cardiac patient, more frequently, actually weekly, after 28 weeks of gestation. And whenever she feels a little bit of shortness of breath, even at rest, or even performing routine, procedure. One more thing I just want
to you. Yeah.
Yes. The only thing I just wanted to add is we can observe a patient having a little bit of fatigue when she walks from the waiting area to your consulting chair. Even if you find a little bit of breathlessness, we can actually go for further assessment.
And I just want to know one more thing from you. Once the patient has delivered, you mean all her problems of heart disease goes off, or you still have to be a little more vigilant in a postpartum state? Sometimes the patient has delivered, now there's no problem, all headache is over. Is it something of that sort, or you have to be a little more vigilant? And around what time of the period? Yes.
Actually, there are major shifts with regards to intravascular volume. The blood pressure actually goes down for first 24 to 48 hours. So we are like we need to be very careful, because after that second day, the blood pressure starts rising. That is one point. The other thing is we need to be vigilant about respiratory system. So this particular shift of fluid may lead to pulmonary edema as well. So with regards to symptom, with regards to clinical features and further investigations, we need to be monitoring. And there is some rule of 5 which I couldn't find in literature, but it was said that 5 minutes, 5 hours, 5 days, and 5 weeks are the points which we need to keep in mind with regards to pulmonary embolism, pulmonary edema, as well as postpartum infection, which will again aggravate the cardiac condition of the patient.
Fine. So once the patient is delivered, doesn't mean that you are relieved of everything. You still have to keep the patient under watch. Yes, correct. Okay, fine.
Yes,
I want to ask Dr. Surekha, what are the signs and symptoms of heart disease in pregnancy? And can you predict that this patient could be having, or this patient could have some problem later on during pregnancy? Is there some way you can do it? And what are
Madam,
the
I
signs
just
and
wanted to
symptoms?
add something to the previous session. Can I add that?
Yeah, quickly
Just I
you
want
can add
to
something.
highlight that as soon as the patient delivers, the pressure of the gravid uterus in the vena cava releases. That is very important, and the venous return to the heart suddenly, increases. That is when we have to be very careful, and that is when the patient may land into CCF, and that's why we advise the diuretic should be given immediately after the delivery of the. So that is what the CCF immediately after delivery of the baby is. So
No,
as
you say,
my
but
question is concerned, madam.
no, you don't give diuretics immediately after delivery of the patient unless patient has some problem as such. We don't give something which is uterotonic, which will increase the cardiac output, but we don't give diuretics,
We need to keep it ready, just
That's
ready.
right.
Yes.
That's right. We don't give it routinely, but you need to keep it ready. That I agree with it. But you don't give
Only in the hypertensive, if it is the hypertensive patients, then only it will be careful.
Yeah.
And for that is the only reason to prevent the pulmonary edema, the diuretics is indicated at that time. It's close monitoring.
Right.
And another previous one I want to add, the rule of 5 is very essential, very remarkably said by previous. Another is the 5 weeks, another was the 5 months for the cardiomyopathy is increased to another 5.
Right. Okay. So we'll be discussing that later. Now that Dr. Suranjan has already added something, I want to ask, what are the symptoms and signs? Can you always predict that this patient, this is a typical signs and symptoms of patient with heart disease, or could be normally also could be found in a patient with during pregnancy, or if she has some problem otherwise also apart from heart disease?
Certainly, madam, certain symptoms of pregnancy mimic those of heart disease. Like in pregnancy, we will see a rise of the heart rate by 15 beats per minute. Patient already will, because of the rising gravity uterus, she may complain of breathlessness. And if there is the gestational edema also is common in between the two. So these are the symptoms which mimic. Even the systolic murmurs, these are called as mammary murmurs, which are seen on the right heart borders. These are also commonly seen. So these may mimic with that of heart disease. However,
just one. I don't know how many of us really auscultated the chest, to be very frank, to be aware of that systolic murmur, but you need to keep it in mind that murmur is there, Okay. The next slide, Dr. Amaya.
But if there is a diastolic murmur, if there is a grade 3 and above systolic murmur, progressive dyspnea is there, PND is there, then patients having chest pain, then cyanosis, clubbing, again these are certain features, clinical features will suggest to you that again a cardiomegaly which is documented, arrhythmias, you should always not only auscultate the apex beat but also auscultate in the second intercostal space if you want to identify certain murmurs of congenital heart disease, like the machinery murmur which you've seen in ASD, these murmurs. So you just
basically
not
it's a
focus on
clinical,
that.
these are the clinical features which should be kept in mind whenever you encounter a patient of a heart disease, and even otherwise any normal patient. At the first antenatal visit, the chest has to be auscultated. At least you try and auscultate and find out if there is any possibility of, if there is any presence of any cardiac anomalies or cardiac murmurs that you find it. I want to ask Dr. Danny Laliwala, how much importance do you give it to New York Heart Classification, number one, and what is the flaw of this New York Heart Classification? We all follow it, but what is the flaw? What is the negative effect of this or negative point of this New York Heart Classification?
So usually if a patient comes with NYHA classification grade 1, we may just consider it like the normal phenomenon of pregnancy and may not pay too much attention to it. But as the grade increases, with the physical activities, if the patient is getting breathless, then we have to really see that whether is she falling into a heart problem or not. So that is the main indication of following NYHA classification.
Fine. And suppose if you feel that this patient could be having some sort of a cardiac problem, what are the other investigations that you would like to get it done from the patient whenever she comes to you for any checkup?
Fetal 2D echocardiography plays an important role in this because we can actually see what is the structural status, what is the cardiac function of that patient also. ECG can also tell you, but more interested in ECGs are looking for any arrhythmias over here. X-ray chest, I would not usually do it in a pregnant patient unless there is a really big need with an abdominal sheath.
Yeah. Now I would like Dr. Amaya to take over that. How do you go about then counseling the patient? Dr. Amaya, please.
So now, since we've understood the physiology and the impact of pregnancy on the heart and the heart on pregnancy, let's try to go one step further and realize whether we can predict the risk in a pregnant woman who has got heart disease. And here we have certain scoring systems. And I will start by asking Dr. Surekha. Dr. Surekha, can you tell us whether certain scoring systems will help us screen about cardiac disease in pregnancy?
So this scoring system, there are various scoring systems. One of the scoring system is was by Siu et al. And another scoring system is CARPREG, the Cardiac Disease and Pregnancy Study. So this is a CARPREG study which uses certain predictors like a prior cardiac event. So certain points are given for these, and depending on that we can predict, like a prior cardiac event or arrhythmia. What is the baseline NYHE classification? Is it 1 or 2 or 3 or 4? So if it is 3, 4 associated with cyanosis, then the scoring point 3. Is there a prosthetic valve? What is the ventricular function? Is there any dysfunction? What is the echocardiac status? Left-sided valve disease? Or is there a pulmonary hypertension? Previous existing coronary artery disease? Any aortopathy, like dissection of the aorta? So no, any intervention was done, and so this would give us the risk assessment, and depending on that we could consider the patient to be a mild risk or moderate risk or severe risk. And again, what kind of cardiac disease is there? It's a risk index has a good predictive value depending on what lesion is also existing. So if the existing lesion may progress also, to have to again do the risk assessment of various stages of the pregnancy, and depending on that we can predict whether this patient is going to land into cardiac failure and any other complications.
Okay, so the important points to summarize are that this scoring system involves past events like past cardiac history, present condition by clinical and imaging, and also other variables, that the presence of comorbidities, patients' medications, etc. What we need to remember is that it has got a high negative predictive value. In other words, if the score is low, this patient usually does well in pregnancy as compared to if the score is high. And it should be routinely used to understand the assessment and improve the prediction of the risk before and during pregnancy. Now, let's move on to another important part, and that is preconceptional counseling. I would like to ask Dr. Nayak, sir, how do you counsel the patient who is now recently married, has got an existing heart disease, and desires to have pregnancy?
Okay. Patient is recently married and she is already knowing that she has got a heart disease. I would like to know what type of a heart disease she is having, whether it is a congenital heart disease, whether she is symptomatic, what activities precipitate or aggravate her symptoms. If she is operated for any congenital heart disease, whether there is any valve replacement done, whether the valve is a biological valve or a mechanical valve, or whether there is any balloon valvotomy done, or whether there is any sort of a heart disease because of blocks in the cardiac vessel. So depending upon what type of a cardiac disease she has and what are the aggravating factors, I will assess what is her risk of aggravating cardiac condition during pregnancy. If she is having something like a very high degree, very high risk of getting the cardiac disease aggravated during pregnancy, maybe we'll have to involve a cardiologist also in counseling and assess the risk and then come to a conclusion whether pregnancy would be safe for her or whether she should not go for a pregnancy at all. Now, today with so many advances, we are seeing lot of women coming with the pregnancy and they are on anticoagulants. They are regularly monitoring. They are monitored during the pregnancies, and relatively the pregnancy and continuation of pregnancy has become much safer compared to what we used to see in maybe 20, 25 years ago. So I don't think of heart disease is really a contraindication to become pregnant, but all these factors will have to explain to her. Now, if she's on anticoagulant, whether she is taking warfarin or whether she is on heparin, So that again we'll have to counsel, because if she's on warfarin, as soon as she becomes pregnant, we'll have to switch over to heparin, so as to avoid the risk of congenital warfarin syndrome in the baby. So all these factors we'll have to consider. Also, the cost involved, the hospitalization cost. If she is having a severe degree of heart disease, she may require hospitalization through a large part of her pregnancy. So even the economical aspect of pregnancy we'll have to discuss with her, and then take a call whether pregnancy will be safe for her.
So I think important points that Dr. Nayak has said is that yes, we need to assess the risk. She will be a high risk pregnancy, and therefore we have to be more vigilant. We must ensure that her medical and surgical status is optimal before she embarks on pregnancy. And if it is not, then appropriate medical and surgical therapy should be done before pregnancy. During pregnancy, we need to look at the maternal and fetal risk, prognosticate her progress in pregnancy. And last but not the least, like Dr. Nayak said, she must be preferably delivered and taken care of in a tertiary care center where there is a backup of a cardiologist, a critical care unit, and a high-risk obstetrician. So therefore, I would like to ask Dr. Suranjan, what is the risk-based classification of cardiac disease? We already know the standard classification, which is congenital, rheumatic, cardiomyopathy, ischemic, and others. But what is the risk-based? What is the risk-based classification of heart disease during pregnancy?
There is the World Health Organization, there's a low risk, medium risk, and high risk. They've classified it. With the low risk, the arterial septal ASD, VSD, PDA, mitral stenosis degree 1 and 2, and corrected phallostatology. These are the comes under the low risk group. These are purely with the cardiac lesions, but no comorbidities like diabetes or etc. Other complications. And the medium risk falls under mitral stenosis grade 3 and 4, and mitral stenosis atrial fibrillation and atrial stenosis, and phallostatology if it is uncorrected. And the high risk group is the pulmonary hypertension, falls under 25 to 50%, and also the Eisenmenger syndrome, aortic coarctation with valvular involvement, and Marfan syndrome with aortic involvement. These are the categories of the low risk, medium risk, and high risk. Accordingly, we have to deal the patients.
Okay, so the risk is of probable mortality. So 0 to 1% in low risk, 5 to 15% in medium risk, and 25 to 50% in high risk. So these seem quite complicated and lot of names and lot of criteria. Could you simplify for us, Dr. Suranjan, what would be the patient who is not likely to make it well in pregnancy on your first evaluation? Certain poor prognostic.
Poor prognosis are those who have got the history of heart failure, ischemic attack, and stroke. And along with it, arrhythmias, baseline neoclassical heart disease association class 3 and 4, and MB area of 2 centimeters square and AV area below 1.5. And ejection fraction is less than 40%. These are the poor prognostic indicators. And also the pulmonary hypertension group. If it is a pulmonary hypertension group, there are additional, they are the poor prognostic. Pulmonary hypertension is a really problematic one. That should be discouraged. I hope we will come in the later half. Yes, and additional risk factor is associated with the anemia that should be corrected. Infection, if she is of the infection, hypertension, exertional dyspnea, everything, weight gain, gradually obesity is a real toll, and multiple pregnancy, pain, and intake of tea, caffeine, alcohol, that's also not good, and use of anticoagulant drugs. These are the additional risk factors which can aggravate the cardiac problems.
Okay. We move on to Munjal. The low-risk patients are mainly the congenital heart diseases, which are small in size, mild in variety. So we start with the first case, Munjal. She is a 27-year-old primate, 12 weeks pregnant, history of small VSD, which was repaired in childhood. She has been asymptomatic since then, not on any medications. Do we really have to worry about her cardiac disease, or it was just an event in her childhood?
So basically, she had this ventricular septal defect. It is surely going to make her a bit high risk patient. When it comes to 12 weeks gestation, there are not a lot of hemodynamic changes that we are expecting to happen in her body. So we are going to monitor this particular pregnancy with through two particular regards. One is maternal aspect and the other is fetal aspect. When it comes to maternal aspect, routine antenatal checkup is fine, but I would like to monitor her more in her second or majorly late second trimester and third trimester as well. So when it comes to this particular case, with regards to PSD, I would like to evaluate her in form of symptom, sign, risk factor, and examination. I would like to definitely go for cardiologist opinion, and ECG can be done even at this particular stage to rule out any other anomaly that we are missing or we might be missing. And with regards to further workup, if there is abnormal ECG, honestly, I'm not going to go for BNP, that is brain natriuretic peptide, but these two things, ECG or even raised BNP, would indicate her to go for echocardiography, maternal echocardiography. And with regards to
I think Munjal,
Yes.
she had got a congenital structural defect which was repaired. It was repaired
yes, sir.
quite some time back in her childhood. Luckily, she has had no symptoms. So before she embarks on pregnancy, we've all said, and you've emphasized that pregnancy is a load on any cardiac disease. Therefore,
Definitely.
I think it would be prudent, and the cardiologist would be emphasizing on the point that we need to look on 2D echo whether that
Yes.
particular septal defect is now properly repaired
Sealed off or not.
and doesn't have any kind of leakage, etc., before she embarks on pregnancy. So I think
True.
ECG is fine, but I think in a structural defect which was there, which has been repaired, we want to check the persistence of the repair and whether
Yes.
it has not deteriorated over a period of time. We'll quickly move on because we are fighting time. So therefore, any specific care that you will do during delivery, did she require any specific antibiotics? Does she require any specific monitoring, etc.?
So just before one thing only, that fetal echocardiography I would recommend at around 18 to 22 weeks with regards to, because she is having congenital heart disease, to rule out fetal congenital heart disease. And yes, with regards to delivery, as earlier discussed, we will be having Lasix and diuretic ready with that. Antibiotic prophylaxis, again a controversial part, because some associations do prefer antibiotic prophylaxis only in those patients who are having prosthetic heart valve or history of endocarditis or cyanotic heart disease. So with regards to this particular VSD, no antibiotic prophylaxis. But yes, when she goes in delivery or labor, routine antibiotic prophylaxis would cover the additional risk that she might have with regards to VSD.
Okay. Now, moving on to Dr. Surekha, the second type of milder lesions are usually the regurgitant lesions, and one amongst them is mitral valve prolapse, which is known to have the best prognosis. Have you ever encountered any patient with mitral valve prolapse in pregnancy? And what is your take on regurgitant lesions, either mitral or atrial or aortic, in pregnancy?
Dr. May, thank you for that question. As you have said, as compared to the mitral stenosis, the mitral regurgitation patients will fare better. Now, as far as mitral valve prolapse is concerned, it doesn't have much of an effect on the prognosis of the of the pregnancy. It fares much better. We have encountered lots of patients, but as far as my experience is concerned, these are faring better than the mitral stenosis. However, we should always be careful about these patients, because sometimes what happens, these mitral regurgitation patient also may land up into, if associated anemia is there, fever is there, these patients also we should take care of very well. Okay. And as far as, have you asked me the question of mitral stenosis also?
No, we are coming to stenosis. We'll come to stenosis in a minute. So,
Okay.
Regarding regurgitant lesions, what we do understand is that they are generally well tolerated in pregnancy because these are younger women. So, the degeneration is still progressive. They do well with the standard treatment. But like you said, if there is a risk factor like infection, like fluid overload, they are likely to go in CCF. We must ensure that they don't take ACE inhibitors in pregnancy. but they can continue their beta blockers, and like stenotic lesions, antibiotic prophylaxis is recommended in these patients. We move on to Dr. Arun Nayak. Sir, what about complex congenital heart disease and its risk in pregnancy? With a mild one, we are certainly more hopeful. But if it's a complex one, there is reversal of shunt, it's a complex tetralogy. What would be the risk? Is it more? Is it less?
I would certainly involve cardiologists in the management team because as an obstetrician, we can take care of a baby, we can take care of mother in the normal circumstances. But then when there is a complex lesion, it's always better to take an opinion of a cardiologist, discuss with the cardiologist what is the risk, how much is the flow getting affected, how much is the compromise in the uterine blood flowing to the baby, because not only the cardiac the heart condition but also the blood flowing to the baby is also important. If there is a complex lesion and the uterine flow is compromised, baby may start developing IUGR, and we may have to intervene even earlier. But as far as the heart function is concerned, how much is the flow which is coming out, whether the patient is becoming symptomatic because of reduced cardiac output, whether there is any cyanotic episodes, whether there is any increased breathlessness, and all these condition factors will come into picture, and accordingly we'll have to start treating the condition. The complication which may occur in these women is probably if there's reduced output because of the complex shunt, patient may have sometimes episodes of patient may have episodes of giddiness. She may have episodes of suddenly feeling giddy and falling and then getting injured. So depending upon her symptoms and severity, we may have to advise her rest at home, or if required even hospitalization much earlier.
Okay. So I think a very important point that Dr. Nayak has said, that each congenital anomaly has to be an specific anomaly based risk, and take a cardiologist's input so that you understand the risk and the hemodynamics of both the defect as well as the extra load of pregnancy can be better managed. We move on to the next case. This is a fairly common case scenario that we see. A 32-year-old primee with 5 weeks amenorrhea, UPT is positive. She's a known case of rheumatic heart disease with mitral valve stenosis. Mitral valve replacement was done at the age of 18 years. It was a critical mitral valve that time, and they had to go ahead with replacement. She is on digoxin, beta blockers, and warfarin. Dr. Suranjan, is it a challenge in pregnancy?
Of course, it's a challenge.
So do we continue,
because of the positive.
Do we continue or not?
It all depends. We have to discuss regarding the concerns of the gravity of the illness or the future prognostic. We have to discuss with the patient the desires of the pregnancy, how much intense desire is the pregnancy the women want. Then accordingly we have to discuss the relative risk of it, and accordingly, as it has been discussed previously stated, that she should be delivered in such an institution, tertiary care. All person costs it will be discarded. And if she desires, then we have to continue it with all precautions. Then just because the process is valves, the regular control of the coagulation profile, we have to change shift. It has to be monitored, and this valve may lead to pulmonary hypertension. What the status we have to examine. All sorts of things along with my cardiologist friends and the critical care persons we have to discuss, and probably these groups may land in Caesar, or sometimes delivered in early preterm delivery may land in. So all the pros and cons to be discussed with her, and accordingly this physiological blood volume, how much she will accommodate, that is also to be encountered, that is has to be discussed with it, and accordingly whether she is on the digoxin and the beta blocker, whether she developed arrhythmias or not, that is also to be, we have to deal with accordingly. And beta blockers should be avoided at that time if the cardiologist advised the choice of beta blockers to be maintained. And digitalization, and we have to use the digitalization of the heart, and according the blood electrolytes to be monitored, the potassium and all things with the ECG monitoring, it should be done. And this compassion, this pregnant patient, may result in rapid decomposition. Sometimes it has systemic circulation, that correct contraction that makes particularly hazardous, certainly. So induction will be preferably very cautiously we have to do. The uterine contractions are problematic. So we have to do that fluid replacement consciously and repair and replace the particular mitral valve. It has been done, and what we have to take care of it. She should be monitored in a close setup in a critical unit. So we have to evaluate the symptoms, evaluation of the risk, and care, and deal with the prognostic factors.
Okay, thank you, Dr. Suranjan. Dr. Surekha, quick word, would you continue this pregnancy or tell them to terminate this pregnancy? Dr. Surekha?
Hello. Yes, Dr. Aman. Are we talking about the mitral stenosis patient?
Yes, the mitral stenosis. She's been operated 18 years back. She's now 32 years old. She's 5 weeks pregnant. UPT is positive. She is compliant, taking her medications. She's asymptomatic at present. Would you tell her to
patient who is asymptomatic and NYHA grade 1 or 2 and already the balloon valvectomy has been done. I think she had a compliant patient also. So we can consider that the risk would be mild to moderate for her only. And if she's compliant already and under good care of the cardiologist, I think she can continue the pregnancy because she's 32 years already. So if she delays or something, she may not be able to. I think she can continue the pregnancy.
Okay. Now, Madam, Dr. Suranjan has already told us about the risk of mitral stenosis worsening in pregnancy, the risk of edema, the risk of arrhythmias, the risk of embolism. How is aortic stenosis different from mitral stenosis as far as symptoms, evaluation, prognosis, and care?
Now, as far as aortic stenosis is concerned, again, the stenosis, we have to see how much the severity of stenosis is. So if and what is the functional status of the left ventricle? So how is the function in mild to moderate aortic stenosis with good left ventricular function? Then the pregnancy is well tolerated in this case. But if the aortic valve area is reduced below 0.7 centimeter per square and the markedly reduced left ventricular function, then again the risk for the pregnancy increases. We have to look for dyspnea. We have to look for chest pain, angina sort of chest pain the patient will have, and we need to really monitor the pregnancy well with the help of a cardiologist. So there has to be a multidisciplinary team here. The antenatal visits will be more frequent in this case, and she may require admission and care. Depending on what is the valvular status and what is the function of the left ventricle, depending on that, she may need valvoplasty also if it's a severe aortic stenosis. And of course, we need to monitor her throughout pregnancy and then decide whether she, what kind of labor and delivery she is going to undergo.
Madam, they say usually spinal and epidural should be discouraged in aortic stenosis. Do you agree with this, and what is the rationale behind this thought?
Now, because we know that as soon as the spinal anesthesia is given, the blood pressure is going to fall because of the vasodilatory effect. So this is going to be hazardous for a patient, or even the epidural anesthesia and spinal anesthesia would be hazardous for a patient of aortic stenosis. Thus, the general anesthesia with a very good cardiac anesthetist is preferred in these patients of aortic stenosis.
Okay. Thank you, madam. I think it was a very important message that we need to convey, that even the anesthesiology team, in addition to the cardiology team, should be prepared when we are tackling such complex situations. Over to Dr. Sujata, who will take us through the journey of managing the heart disease in pregnancy with specifics of antenatal and intrapartum care.
Thank you, Dr. Ameya. I would like to ask Dr. that we have already decided now this patient to continue with the pregnancy. What would be your team approach, and how will you take care of her during antenatal period? How often would you call her, and what are the things that you would like to do during antenatal period? And what would be your team approach? And where you do ask her to deliver? Everybody said tertiary healthcare center. So that is fine. So I
would deliver in a tertiary care center only, and I would call these patients every 2 weeks up to 7th month is completed, and afterwards maybe even every weekly I'll be seeing. So during each time you basically look whether she has tachycardia or no. Look for pallor in these patients because anemia can also precipitate a failure. Look for cough, dyspnea, whether she is increasing too much of weight, is she developing pulmonary edema, and see how she is feeling while walking and while resting. Any changes in that is more important than what you just see at a single event. Then these patients need to be evaluated by a cardiologist also. And then during labor, you want me to say?
No, no, no. I want to know what dietary advice would you give it to her during
Yeah.
antenatal? Anything
So
specific that you would
yeah,
like to tell her?
yeah.
Any
I would
lifestyle
like her
modification
to
that you would want to tell her?
yeah avoid too much of exercise. She can do a normal routine exercise, but strenuous exercise should be avoided during pregnancy. You should restrict her salt intake, avoid smoking, and any treatment like for pallor, for anemia, for infections, any PIH has to be treated immediately.
Okay. And what about iron and calcium supplement for these
So the
patients?
routine,
Yes,
routine iron and calcium supplement need to be supplemented.
need to be given. Fine.
Yes.
I want to ask Dr. Munjal, what would be the thing that you would try and manage her in labor room? Dr. Munjal?
Madam,
Yes.
yes, ma'am. First thing is when she completes 39 weeks of gestation, we can induce that particular patient between 39 to 40 weeks of gestation. With regards to this particular induction, we will just keep simple monitoring of fetus as well as continuous monitoring of maternal vitals as well as the respiratory system. We don't want her to get pulmonary edema at any point of time. So, with regards to induction, if she has completed 39 to 40 weeks, I will induce the labor. Oxytocin again is a preferred agent. Obviously, we are having our own experiences with various agents like dinoprosten gel is something that can be used as well if you are comfortable with that. So, whatever agent we are fine, we can use it. We are comfortable with it. When she is progressing properly, we can have a partograph. Everything is well, as you said. Darifalin, Dexona, and even diuretics are to be kept ready. If she is to go in, with regards to
What
first stage,
about
yes,
her
definitely.
position? What about her position in first stage of labor? Very
So
important.
we would like to avoid inferior vena cava compression. We would like
Right.
to avoid inferior vena cava compression. So if we are noticing any kind of hypotension or even hypotensive effect, we would like to push uterus a little left. She can be given, and she needs to be given proper position with regards to supine position is something not which is going to favor her anytime. And whether we are going for delivery or cesarean, analgesia is of utmost importance. So if we are planning vaginal delivery, yes, labor analgesia is something which will reduce catecholam and release, leading to inhibition of any fluctuation with regards to heart rate as well as the volume, plasma volume that is going to have overload on heart. And obviously, as written in anticoagulants, she is definitely on unfractionated heparin if she is on continuous anticoagulant.
Yeah. Correct.
Yeah.
I want to know what about oxygen, Munjal. What about oxygen inhalation? Would you try and give it to her? Because some of the patients are very uncomfortable when you give them oxygen by mask. That nasal, they think that they just don't like it. But when you give it to them by mask, some of them are very uncomfortable. So how would you counsel the patient? Yes, I just want to know that.
Pulse oximetry is something I will like to have continuously. Like SpO2 is, if it is 98, 99, I am not going to worry about that much. But yeah, during labor, oxygen mask is there. It needs to be there, and I would counsel that. See, this is a baby. You have made effort for last 9 months. She is going to deliver within few minutes, and you are going to see that baby alive, and she or he will be needing you as well. So this is something required for your life. That is the counseling.
Correct. So that counseling is very important so far as oxygen this thing is concerned. One more thing I want. What about IV? Yeah. What about
can
IV?
I interrupt
here? Yeah, Dr. Arun.
I don't agree that all patients need to be induced, because if patient is going to go in spontaneous labor, I would always prefer patient going into spontaneous labor and delivering, because induction will always have a risk of patient not responding to the induction and then we landing with some interventions. Also, once we induce, we are committed. I think if patient is stable, she is compliant, she is not breathless, then I think we can just wait for the spontaneous labor. And most of the heart disease patients, they don't reach the 40 weeks. Most of the heart disease patients will deliver much earlier, may not be even reaching 39 weeks. So I would be little hesitant to induce labor in heart disease cases.
Yeah. So the
And
thing is
again, about your
spontaneous vaginal
oxygen.
delivery as much as possible, as
Yes,
far as
about the
possible.
oxygen, if patient is comfortable, she is not breathless,
Huh.
then I don't think all patients will require even oxygen
Oxygen,
supplementation.
correct.
But if she is breathless, yes, try to find out whether why she is breathless. Maybe the position itself, she is breathless because of the lying down position. So we can give a propped up position, and with propped up position, maybe she is comfortable and won't require even oxygen.
Yeah. Dr. Arun, I also want to know what about IV fluids, or will you just keep the vein patent, or would you just give a very slow IV on the patient just to keep
I
it?
always recommend whether patient is having heart disease or any medical disease or no disease. I recommend that all pregnant women, once they go in labor, there has to be accessible venous, or the vein flow has to be there. Now, this vein flow, because if patient develops some complication, if she goes in shock or if she develops some complication, we should have access to the IV line, and that's why
Correct.
all labor patients there should be vein flow which is to be inserted.
Right.
Now, for heart disease, we have to restrict IV fluid. So I wouldn't be giving very fast IV fluids, but maybe just a patency pint or just maintenance pint, which will be just going very slowly. That should be okay.
Fine. I just want to know one more thing. What about infective endocarditis prophylaxis?
Yeah, there are certain factors which aggravate the risk of patient going into the heart failure. So even during the antenatal period, we have to warn the patient like excessive weight gain, hypertension, if she gets any infection, if she's smoking or taking alcohol, then also any surgical procedure, she can develop infective endocarditis. So she should be warned that she can go in infective endocarditis following any procedure or if she gets any infection. So we should give prophylaxis against infective endocarditis. And definitely once she comes in labor, because we will be doing many times, we will be doing repeated vaginal
For vaginal
examination,
examination.
we'll be doing probably catheterization. And that's why once she comes in labor, I will always prefer giving her antibiotic prophylaxis.
Okay, fine. Thank you, doctor. I want to ask Dr. Suranjan, how will you manage a second stage of labor? She has gone through the whole first stage of labor. Now she is fully dilated. How would you manage the second stage of labor? Everybody said cut short the second
Usually,
stage of labor. Yes.
of course, this compulsory mechanism, we always assist her to delivery, avoid her strain. So we can use the Ventus is a one suppressor depending on the position of the fetal head, and if required, the forceps.
Fine. So
That will cut short the labor.
Yeah, as far as possible,
As
you
far
try
as
and cut
possible,
short. Yeah. And what about once
cut
she has
short the
delivered?
labor.
Correct. Once she has delivered,
Sujata,
how would you
again
manage?
here.
Yeah. Tell
Yeah,
me, doctor.
Sujata, again, delivering in propped up position is not very comfortable.
Very comfortable. So that
Delivering
time.
in propped up position will be having difficulty in delivering her. So if you recollect, there was a position, if there's some PGs, for knowledge of PG students, there was a position which was described that was called vulture's position. And this vulture's position is a modified propped up position. The patient is brought to the edge of the table. Her legs are not hanging. It's something like a modified lithotomy position,
It's
but the
an
legs are not hanging.
exaggerated lithotomy
Yes,
position.
the legs are falling down so that there is no increase in the venous return. And also the patient is given back rest. So she is sort of a semi-propped up position and legs hanging down. So it's comfortable to the heart. The only thing is that there is adequate room available. We can conduct the delivery well because patient is brought to the edge of the table. The precaution that we have to take is we have to have some support for the baby because baby shouldn't suddenly come out and then baby shouldn't get injured. So that precaution we have to take.
Dr. Suranjan, how would you manage the third stage? You have already delivered the baby. Baby is crying. You have cut the cord. Now, how do you manage the third stage?
Just with the channel, I avoid the oxytocin bolus drip. The oxytocin is a safe option. Avoid the bolus and argumentin never.
Yeah, so you put oxytocin in the drip. Yes, yes. Okay.
Oxytocin in the drip. And no question of massaging uterus, that will induce the embolism.
Correct.
As soon as the delivery and after placenta afterbirth is delivered, uterus is usually contracted. If it is oxygenation is as it is been advised already that the pulse oximeter oxygen saturation is okay, uterus will usually contracted. But in spite of that, there is every chance of PPH in these patients. So we have to be very cautious regarding it. We shouldn't be left alone with that contracted, and oxytocin should be continued. Oxytocin
So how
should be
many
continued.
hours would you keep her in the labor room after she has delivered for observation, doctor?
observation, usually 6 to 8 hours is a close monitoring. If it is gradually is weaning off, then an early ambulation will advised.
Fine. Generally, we
Providing our
leave, yeah,
status.
normal patients we leave for about 2 hours. These patients we have to leave it for, keep them under observation for a little longer time as such, so as to try and, yeah, any complication. Dr. Munjal, I want to ask you, in case you have to decide for a C-section, would it be for because she has got a heart disease, or would it be for an obstetrical indication?
Madam, cesarean section is something that I will do for only obstetric purpose, because cesarean delivery would carry additional risk with regards to fluctuations in hemodynamic changes as compared to vaginal delivery. So stabilization of hemodynamic circulation would be better with vaginal delivery. So I wouldn't go for CS until unless it is for obstetric purpose.
Yes, and if at all there are some certain patients with heart disease like coarctation or Marfan, what type of an anesthesia? Of course, you'll say let the anesthetist decide, but you also have a little bit of choice in the sense of you can discuss it with the anesthetist. So what type of an anesthesia would they prefer it? Yes.
So until unless contraindicated, it is new rectal anesthesia. There is spinal and epidural, which is indicated for cardiac patients because of stability and stabilization of hemodynamic circulation. Now, with regards to epidural, it is having an upper edge as compared to spinal. There are two basic advantages. With regards to epidural, it has a slower onset, but as stable hemodynamic changes after epidural analgesia, and as well it will not allow this catecholamine release, leading to fluctuation. So epidural is the preferred agent until unless contraindicated.
Yes, and otherwise general anesthesia would be a preferred.
General anesthesia in case of reduced afterload, in any condition that is having reduced afterload, that is reduced output, we would not go for any of this hypotensive anesthesia.
Fine. I want to ask Dr. Surekha. Now everything is like she's about to take discharge. What all advice would you give it at the time of discharge, Dr. Surekha?
Whatever treatment she is receiving, like any medication, the cardiac medication she is receiving, she needs to continue that. So if she's taking metoprolol or any other medication for her status, cardiac status, we have to continue that. Avoid any infection. So we have to take care of the episiotomy wound if it is been there. If any intervention has been done, like a forceps or a ventouse, then we need to take care that she should observe that there is no foul smell discharge from the vagina, and accordingly we need to reassess the woman after 6 weeks, because we consider that within the 6 weeks after the involution has occurred, and so 6 weeks she should be told about what would be the symptoms for which she has to return back. So if she has any fever, any breathlessness, or any other cardiac symptom, she has to return back. That we have to tell her. Continue her iron and calcium, and of course cardiological assessment, and of course contraceptive advice is very important.
I was coming to you for that only. That when will you start counseling her for contraceptive advice? After 6 weeks, at 6 weeks, you tell her postpartum. By then, she said she will think, she will consult her husband, and then she'll get.
I think
you start counseling
immediately postpartum period. That is the most receptive. The patient will be most receptive to your advice when she is in your postpartum ward itself. So you have to ask her. You should, as we know that OC pills are not to be given to these patients because of the risk of thromboembolic phenomena. Then barrier contraception having high failure rate. Thus, what we say, the progesterone only pills or the long acting progesterones, these would be preferred. Now, regarding IUCD, there was a time when we used to say, okay, IUCD causes infection, so it should not be used. But I am not of that opinion. The opinion is changing as far as the IUCDs is concerned. So
IUCD in only a selected group of patients, then maybe you can just do it. Otherwise, per se, patient with mitral stenosis or mitral valve replacement, these are the patients you would not want to do it. But you start counseling when patient is indoors, that's when they are very, adaptable to taking your advice as such, so far as contraceptive advice is concerned, and then you start implementing it when she comes for a follow-up as such. Now,
so you can give her DMPA or NATN. Preferably, we would start her on DMPA.
Yeah, that would be little later, I said, when she comes for a follow-up in a postpartum period. But you start bombarding the patient or start counseling the patient when she is very much there in the ward. Of course, there are some patients we start counseling even in the antenatal period. Antenatal period, they are not very much. I've seen over a period of time, they are not very much. They will just listen to you, but they will not, be very receptive to the same thing. But once they've delivered, that's the time they are quite adapted, or they are quite willing to accept whatever you're trying to tell her. Okay. Now,
Absolutely, that is the window of opportunity.
Nowadays they are preferring not to give DMPA because they say it leads to fluid retention.
Correct. That
So
is
you
also
avoid
there,
DMPA in heart disease patients.
Correct. Yeah. Okay. Fine. Now over to Dr. Amaya.
Yeah. Before that, I'd like to ask Dr. Arun Nayak, sir, what is your take about permanent method of contraception in these heart disease patients? What has been your experience, and what would be the take-home message for our audience? Dr. Nayak?
I think he lost connection, I feel.
Okay. Then maybe Danny, you could take this.
Yeah, the best would be if the males come forward and say that we'll do a vasectomy, but you never know because they don't follow up with you, and then it is lost, and then the females have to suffer. So even if they are willing for tubal ligation, we should do it on the pubertal period only if she's stable enough that time.
That's true.
I would like to. Sorry.
Yeah, tell me, Munja.
Yeah, I would like to add one thing that I just read an article that cesarean tubectomy is something that is having higher failure rate as compared to routine tubectomy. That is like 1 in 200 because of the proximity. So vasectomy
is because of the proximity and what else?
Yes.
And what else during at the time of C-section that you try to do TL? The tube is little more edematous, so by the time, so then there are more.
It will shrunk, right? So the thing is that is why vasectomy is again preferred as compared to even cesarean tubectomy. So
other thing what we can offer to them is a hysteroscopic sterilization in women.
Yeah,
that also gives a good result, and it is safer comparatively.
Yeah, but then people are not very comfortable with hysteroscopic tubal ligation.
Sure, yeah.
Anyway, I think it's not practically done in our country that often. I think the better way out, like Danny said, would be counseling the male partner for going ahead with vasectomy, because every pregnancy is going to be worsening her cardiac status, and whether she is fit enough, then probably motivating her for an interval procedure without the risk of the postpartum period. I move on to Dr. Surekha because she has experience on the maternal death review committee. Which are the patients with pre-existing heart disease where pregnancy is absolutely a no-no, Dr. Surekha?
See, some of the complex cardiac diseases like tetralogy of Fallot, or if we have Marfan syndrome or dissection of the aortic root, even in Eisenmengerization, where there is reversal of shunt, these are the cases where even the aortic stenosis, where the left ventricular function is reduced and the ejection fraction is less than 40%. These are the cases where we are going to avoid, because the mortality is from 50% to 100% in these patients. So even patients of peripartum cardiomyopathy are having really high mortality. So these cases we should counsel that they should not go. So if they are coming in the periconceptional period, then we can advise them not to get pregnant. If they are coming with pregnancy in the first trimester, that is where we can counsel them for medical termination. But we have to remember, for medical termination also, very early medical termination is advisable. If they go in the second trimester, then these patients will suffer the same sort of mortality indices as for if you continue the pregnancy. So best for them is to counsel them depending on their functional status, that they should not go for a pregnancy itself. So Marfan's, Eisenmengerization, complex cardiac diseases, tetralogy of Fallot, look at the LV function, ejection fraction, and decide for the patient.
I think one very important one.
Severe coarctation of aorta also to this.
And the presence of primary pulmonary hypertension.
Primary pulmonary hypertension.
Remember the P for poor, P for prognosis, and P for pulmonary hypertension. Okay.
Definitely.
Dr. Suranjan, my question to you is that we all decided that we need to terminate this pregnancy. So what would be the safest method to terminate the pregnancy in these patients? They already have got a complex cardiac situation.
Yeah. This patient, there's a DNE is the best option. that the evacuation is the best hand. Just because induction of labor, if the second trimester, that will be more, at that time there will be more risk factor from the cardiac output. And in my opinion, the first trimester and the early second trimester, there will be DNE in the safe hands, will be the better option.
Okay. So the take-home message is that if termination is required, do it as early as possible, preferably in a tertiary institute. Again, good anesthesia,
Yes.
suction evacuation, better method, antibiotic prophylaxis, absolutely essential. But you need to take high-risk consent because the MTP itself is also an intervention and it is associated with a risk to the woman as well. So,
But
now,
if you are doing an MTP in a patient who is not very severe, say mild MS, mild, why can't we do a medical? Can we do a medical?
see, medical would be in a very well compensated patient because
Yeah, so
there
if it
is a
is
risk of incomplete abortion and infection and bleeding, etc. We don't want to get into all those. We want to have a clean cut evacuation procedure and finish everything under our control. Okay, we move on to Munjal now, and Munjal will look at the cardiac risk. We've so far talked about the obstetric issues right now, and now let's look a little bit about the cardiac risk. Obviously, the greatest risk is CCF. So, what's your take? When does it usually occur? How does it occur? What are the risks? How do you know the patient is in India, and how would you manage this patient?
So basically, congestive cardiac failure happens usually at the time when the plasma volume actually is high. I mean, at the maximum, like around 30 to 32 weeks, there are maximum chances of CCF. Then comes the later part of third trimester and delivery and labor. These are the stages where immediate sudden shift of larger volume of fluid happens when it comes to extravascular to intravascular. So in this particular patients, we would be having some symptoms like dyspnea, orthopnea. There will be shortness of breath, chest pain, and even nocturnal cough. Now, these are the patients which on examination would elicit some murmurs as well as basal cramps. And on investigation, we would find pulmonary edema as well as congestive cardiac failure. So these are the patients where we need to actually go ahead with immediate investigation and management. And this particular CCF would be requiring some loss of fluid as in form of diuretics as well as in case of preeclampsia, there will be hydralazine. So hypertension, anemia, and infection. This three would aggravate CCF. And this particular thing, in case of hypertension, we would initiate with hydralazine bolus if there is severe hypertension, or we can go for infusion of hydralazine.
Okay. Moving on to Dr. Surekha. Madam, when would cardiac surgery be indicated in these patients of heart disease? And what are the different types of cardiac surgeries that we offer to these patients? And what is the prognosis as far as maternal and fetal? So first, let's look at stenotic lesions because those are the ones which are usually more severe and more common. So what about valve replacement? Dr. Surekha?
I think she also is having some net issues.
Okay, so maybe Danny, you could take it. You come from an institute which is one of Mumbai's premier heart institute.
I'm working with Dr. Vinita Salvi.
Yeah.
So basically, if there is a stenotic lesion, the closed procedures would be much beneficial in these patients, especially the closed mitral commissurotomy is preferred over, and that we're going to do only if the patient becomes symptomatic. If the grade of NYHA also changes from say grade 1 to it becomes 3 or 4, and she goes into failure and all those. So if there are precipitating factors, then you would try and do. So closed CMC would be my first choice in these patients. If the patient has to undergo open surgery, then I would prefer keeping everything ready for an emergency cesarean section also ready at the same time.
Okay. So again, the question comes about which valve do we use? Normally, these are young patients, and you use.
Yeah. So you have mechanical valves and you have the biological valve, that is usually the porcine valves. Now, mechanical valves, they have more chances of thrombotic phenomenon happening along with it. Now, as far as possible, you should try and do these surgeries before they become pregnant. So we are considering only if she becomes, there is a failure, maternal morbidity, where you are expecting a mortality, then only you would try and do a surgery during pregnancy. And I would prefer a mechanical valve. What I mean, porcine valves, they are usually, they don't survive for a longer period of time. They need to be replaced after periods, after
10
say
years.
maybe 5 years or 10 years. Yeah.
10 years.
Yeah. Also, we need to keep in mind that when these open heart surgeries are being performed, the patient will be put on a heart-lung machine, and that usually causes placental hypoperfusion, and fetal loss also could occur.
Yeah. So I said we have to keep for emergency LSCS ready at that same time.
Yes, and also we must counsel the patient appropriately that the priority is towards maternal survival as compared to the fetal survival, and hence appropriate counseling is absolutely essential in these patients. We move on to the other important cardiac medication that we are dealing in more and more in our patients, and that is anticoagulants. Munjal, what are the anticoagulants that we use in cardiac patients? What are the indications? How do we monitor them? And what is the switch therapy? So when do we prefer which, etc.?
So basically, there are various indications. Like mainly prosthetic valve is something where we need this particular anticoagulation. Plus, if she is on some, previously pre-pregnancy state, she is on any kind of anticoagulant. Usually, we would prefer continuation of warfarin till she is diagnosed with pregnancy. Then we would like to shift her to lower molecular weight heparin. Now, there is again two schools of thought. One is if the dose of warfarin is less than 5 milligram per day, we can continue with warfarin without any embryopathy. But still, we would not go for it. So low molecular weight heparin, usually in a therapeutic dose twice daily subcutaneously, is something that is preferred because it is not having any detrimental effect on bone. It is having stabilizing effect as an anticoagulant as compared to unfractionated heparin. But when we are approaching close to 36, 37 weeks, we would again shift to unfractionated heparin because that unfractionated heparin would require like stoppage for only 4 to 6 hours if we are not having any abnormal lipidity as compared to low molecular weight heparin. If we want to terminate this pregnancy, we would require 12 to 24 hours of duration without LMWH before termination as compared to unfractionated heparin, which is like only 4 to 6 hours. So near term, it is unfractionated heparin. And after delivery, we can again shift to warfarin. That is how we would go.
Yeah. So the take home message is 3 choices: warfarin, unfractionated heparin, and low molecular weight heparin. Warfarin, avoid in the first trimester because known teratogenicity. The anticoagulant of choice will be heparin. Heparin could be unfractionated or low molecular weight. If she is at a higher risk for embolism, use the standard heparin. If she is at low risk, you can put her on low molecular weight, and near term, we need to take the call which heparin we will prefer. Postpartum, again, we can switch back to warfarin. Warfarin can be safely given in the breastfeeding period. Okay. Quickly,
One point over here, I would like to just say that if your patient is on warfarin and then she requires an emergency delivery, then it is better to do an LSCS to prevent intracranial hemorrhage in the newborn.
Yeah, true. Quickly, we know that protamine sulfate is the anticoagulant. How do we monitor these patients as far as their coagulopathy is concerned? Do we need
with regards, yeah, sorry.
Yeah, do we need to, Munjal, and what tests do we do to monitor?
So basically, we would have a therapeutic range of APTT with regards to unfractionated heparin. Usually we keep it as 1.5 to 2.5, and that is something where we are playing safe. With regards to low molecular weight heparin, American Heart Association in 2014 concluded usage of low molecular weight heparin has to be followed up with serum level of anti-10A. It has to be around 0.8 to 1.2 unit per ml after 4 to 6 hours of administration of LMWH. Until and unless, if you are not going for it, usage of LMWH must not be done. And with regards to warfarin, again, keeping an eye on APTT is something which is, give an idea about coagulation status.
Okay. We move on now. I request Dr. Sujata Dalvi to present to us a very interesting case. We've saved it for the last, so she'll be taking you through this.
No problem. Thank you so much. We have a very limited time, so we'll quickly go through it. This is a 23 years old primary paras patient with post-dated pregnancy at 40 plus 2 weeks of gestation. She was admitted for induction of labor in view of unfavorable cervix. At the time of admission, pulse, blood pressure, respiration, everything was normal. All her investigations were normal. Antenatal course was uneventful. She underwent an emergency C-section for failure of induction under spinal anesthesia. Intra-op, immediate post-op, everything was uneventful. On the fifth post-operative day in the morning, patient complained of palpitations. Her pulse was 110. Her blood pressure was 180 by 110. Respiratory rate was 28, and hence immediate physician's reference was asked for because she was going to be discharged the next day as such. After 1 hour of that, she complained of sudden breathlessness. Her SpO2 was 86%, blood pressure was still 180, 110. Bilateral basal creps were there, hence injection Lasix was given 20 milligrams IV. Oxygen support with bag and mask ventilation was given, and she had a cardiac arrest immediately after that. So she was revived after 10 minutes of giving CPR as such. Immediate intubation was done in the ward, and she was shifted to MICU, and she was kept on a mechanical ventilation. Our investigations, chest X-ray showed suggestive of pulmonary edema. ECG showed no SCT changes or arrhythmia. 2D echo, which was done, suggestive of global hypokinesia. Ejection fraction was 15%, and all chambers were dilated. ABG showed suggestive of metabolic acidosis. Serum electrolytes were normal. D-dimer and FDP were negative, and EG showed suggestive of hypoxic ischemic encephalopathy. This is our X-ray chest, and that's a 2D echo when you see all dilated chambers of the. So the diagnosis of postpartum cardiomyopathy was made as such. I want to ask Dr. Danny, what exactly is postpartum cardiomyopathy? Can you predict it, or you should just keep it in mind when patient are suddenly like this? This is on the fifth post-op. All throughout.
It is totally unpredictable. You cannot predict it at all, and usually it happens. Heart failure occurs in the last month of pregnancy, or it can occur even up to 5 months of postpartum without any cardiac disease in the past. And the main one thing which we can diagnose it is by showing left ventricular dysfunction.
So it's very important to keep it in mind that postpartum, that's where the rule of 5, what these people discussed it in the beginning, you have to keep it in mind that this is something, it can occur anytime. It generally occurs 1 in 3,000 live birth, advanced maternal age, if there's increased parity, diagnosis, you have to keep it in mind whenever patient is having such type of symptoms, patient needs to be immediately treated, needs to be shifted in MICU, and needs to have some cardiac support so as to try and treat this patient as such. So women who develop pericardial myopathy generally have symptoms. They generally have symptoms before 36 weeks of gestation. In contrast to pre-existing cardiac dysfunction, usually experience cardiac deterioration generally at the end of the second trimester, because that's when the cardiac output and stroke volume increases, and it reaches almost a plateau level latter half of second trimester and in the third trimester as such. Now this same patient in MICU on the same day, she had, mind you, convulsions which lasted for about 3 minutes. So she was started on anticonvulsant. She was assessed for neurological status. EEG showed bilateral cerebral dysfunction. And then she was managed conservatively with injection furosemide, dobutamine, digoxin, ramipril, and L-Doctone. The same patient, Amaya, next one. She remained in coma on ventilator support for 7 days. Tracheostomy was done because all the time the tube was getting blocked. She was on ventilatory support for almost about 14 days. She was given antibiotics and antifungal. Hemoglobin also had dropped in between to 7.4 on day 11. Dr. Danny, any idea why hemoglobin dropped? Because she didn't have any bleeding or anything, but suddenly they found that every day they should send investigations. Yes.
Or because a shift of circulation could have happened.
Correct. So shift of circulation and some amount of blood loss at the time of delivery, and that's the reason hemoglobin dropped. So 2 pack cells were given to this patient. Patient slowly improved. She was discharged on 56 days with ejection fraction of 50%. And on discharge, what advice would you like to give it to these patients? And when would you ask her to follow up? Dr. Danny?
So basically,
yeah, Munjal, yeah, you can speak.
So basically, this patients usually takes 6 months to 1 year to recover. I mean, if the ejection fraction at the time of diagnosis is more than 30%, at least 50% of them would recover within next 6 months. The only advice we would need to give is next pregnancy is going to give a huge threat to her own life. So
would you advise? I wanted to ask that. Would you advise her for next pregnancy?
No.
That's correct. Yeah.
No.
Yeah, I would advise her for the next pregnancy as such. At least this is what I feel. So anybody has any view on that? Would you advise her? Yes.
Contraindicated.
Dr. Suranjan, what is your view?
Dr. Suranjan? Acha, everybody is losing.
We are four actually,
Yeah,
right?
no problem. Dr. Munjal, you can start. Yeah.
No,
So yes,
yeah, I think Dr. Suranjan.
First of all, madam,
bolo,
I think that this is a case which you have handled, and I would like to congratulate your team. Basically, these kind of patients, a high mortality rate.
Yes.
Unless you have a multidisciplinary team, and here comes the role of obstetric ICU, I think.
Correct.
Obstetric HDU ICU, if we have it ourselves, our own obstetric ICU HDU, this is these kind of cases we can save lives. So I think this is a life saved by you people, and I should congratulate you, because there's a really high mortality rate. And of course, I would not advise this patient to get pregnant again.
Yeah.
This is a contraindication for pregnancy.
I would also go with you that I wouldn't advise this patient to go ahead with pregnancy as such,
Okay.
Next pregnancy.
We'll ask Dr. Arun Nayak. He's back, I think. Sir, very bad postpartum cardiomyopathy, patient arrested, patient on ventilator, discharged on day 56. We were lucky to save her and the baby. Would you advise her continuation? Would you advise her a chance of a second
Next pregnancy?
Yeah.
Next pregnancy. Yeah, if she is already developed cardiomyopathy, I will explain to her that if she becomes pregnant, there is again a possibility that she may develop cardiomyopathy. This time, maybe she is lucky enough that we could save her. But next pregnancy, if she develops cardiomyopathy, she may not be that lucky. And this is what I will explain to her and try to discourage her to get pregnant again.
Sir,
but I'll tell you, in Sion Hospital, in spite of giving this advice, we have got patients who have come again with the pregnancy, developed cardiomyopathy in the second pregnancy, and God is great. She survived and then gone home again.
Sir, I just want to tell you with this patient also, her ejection fraction was barely 15% when she had the cardiomyopathy.
And
at
then
discharged over 50 days, it improved to 50% plus. And after 1 month, when she came back to the cardiologist for her cardiology evaluation, they did a repeat echo, and she was asymptomatic with an ejection fraction of 65%. So how each individual heart will recover is a matter of conjecture. Now, sir, my question to you is a very practical question. You are the obstetrician. The husband and wife have come to you with such a scenario. What is your practical advice about permanent contraception to them? They say, Dr. Nayak, we've had enough. It's a second life for us. We don't want to risk the life again because of pregnancy. Could you please guide us? What would be a safe alternative?
Okay. Not only for these patients, for many other patients also, I always advise, wife is not the only person who has to take contraception. Husband also has to take the responsibility. And in fact, some patients I have not gone ahead with MTP, and I have sent husbands to F South Ward for getting the for getting vasectomy done. And only when they get vasectomy done, then I go ahead and then perform the MTP for the wife. So contraception, yes. If she's risking her life with repeated pregnancies, we should tell them that contraception should be used. And if she's a high-risk patient, why subject her to the anesthesia and then the risk of surgery? Husband can very much bear the responsibility and can undergo vasectomy.
Okay.
That is true.
One more question to Dr. Surekha. Dr. Surekha, a lot of recent papers talking about the role of cardiac transplant in such patients. Of course, this patient recovered well, but those who don't, do you see a possibility of cardiac transplant as an intervention in these young patients? Because they have a lifetime to go through. Unfortunately, they've had this at a younger age.
Dr. Amey, I must frankly say that I do not have any experience of cardiac transplantation or any patient which we have dealt with in this way. So, however, now as the update is going on and dilated cardiomyopathy, if the conventional treatment is not successful, then these patients are ideal candidates because they are young patients. So cardiac
transplantation, of course, the centers have to be there and the expertise also have to be there. Then we can go for the cardiac transplantation. However, I do not have any experience about it. So
In fact,
maybe
none
I
of us
should hear
have
from
for
other
cardiac
panels.
transplantation. Yeah. No, none of us have, to be very frank.
So, like everybody said, the prognosis is very variable. Some of them recover absolutely, but mortality is high. And there is a higher risk in subsequent pregnancies. And like Dr. Arun Naik said, they should be counseled against becoming pregnant, and some kind of permanent contraception is essential. So, to conclude the panel, we all agreed that understanding of hemodynamic changes during pregnancy, labor, delivery, and the postpartum period, and more importantly, their anticipated effects on the patient's pre-existing cardiac condition, are important for clinical assessment. The scoring system is to be used for prediction of the risk before she becomes pregnant, and if we are able to appropriately assess the risk, we can counsel her and offer her the appropriate care during pregnancy for the best maternal and fetal outcome. Hence, individual patient's risk requires a lesion-specific evaluation, as all of you said, and all these cases that we saw from mild to severe. And it must be emphasized that availability of a multidisciplinary team with expertise and experience and facilities with diagnostic and therapeutic capabilities, ranging from very good diagnostic cardiac evaluations to excellent critical care units, and more importantly, and most importantly, the patient's willingness and ability to follow a demanding regimen are essential for a favorable outcome. So I think that is the crux of heart disease in pregnancy. On behalf of Dr. Sujata and myself, we would thank Dr. Suchitra Pandit, Dr. Raju Nagarkatti, and Dr. Komal Chavan for inviting us this evening. It's been a privilege to be a part of this important webinar. And I would like to thank the panelists for giving absolutely practical, pertinent, and absolutely clear-cut messages on managing a heart disease in pregnancy in the best possible way with the best interest of the mother, the fetus, and the family at large. Thank you so much, all of you, once again.
Thank you so much.
Ameya and Sujata.
Thank you, Sujata and Ameya.
This wonderful.
We had a wonderful time.
And this took me back to my days when I was working at SAN, and we used to see a whole lot of heart disease. And of course, in the later half of my career, I saw a lot more of congenital heart disease.
That's right. That's right.
But still, it's very important. There are people who are still there, and one must know. I think very brilliant panel discussion, and Arun and Munjal and Surekha. I thank you very much for being there, Varsha. It's been great. I think the viewers have had a lovely time, or rather an educational thing, listening to everything. And Suranjan, thank you for joining in from Kolkata. And of course, the first.
Thank you, Didi.
After the first keynote, following this panel discussion was very, very interesting. And here again, I'd like to thank and Raju for coordinating and getting brilliant people onto the subject. Thank you very much.
Madam, just one important opinion of yours. Do you really see that cardiac transplant will be a reality in these patients with peripartum cardiomyopathy?
I wish.
You have managed so many of kidney transplants in pregnancy.
Kidney transplants, but cardiac transplant, when I was leaving Kokilaben, there was one cardiac transplant in a lady who had undergone peripartum cardiomyopathy, but she didn't survive more than 5 days. But
yes.
What happens is the mortality is very, very high.
Very high, yeah.
Unfortunately, first is the diagnosis, and second is, the patient has to be in the right place at the right time. And I hope in the future, we have more bigger centers and public hospitals where there will be facilities. But it's not looking very promising at the moment. But nobody knew about liver transplant 20 years ago. So it's now become a reality. So I hope and pray that, whichever way we can be able to offer the best possible services to our women at the public hospitals and at the bigger centers, and the care should be affordable. Even for the corporates, we used to always tell our CEOs, these patients who are coming in, they need cost cutting also, because only then we have the services, but we can provide them.
And like it is said in the Gita, I would like to conclude that crisis is integral to human life. That's what Krishna told Arjun when he was about to fight his own brothers. But those who rapidly and correctly counteract it will survive and succeed. I think probably he was talking about heart disease in pregnancy that time. Anyway,
Gita always has a broad-minded thing, whether it is heart disease or whether Krishna talking to Arjuna, it's always a broad-minded thing,
So anyway, from all that seriousness about heart disease, we are approaching Valentine's Day very soon, and you are seeing the heart beating. Let's take the heart in a different way, and let's all enjoy Valentine's Day, and hope that we shower love on our patients and fellowship on all our brethren all over the world. Thank you.
Thank you, Komal madam. Thank you, Suchitra madam. Thank you. Thank you, Dalvi madam. Yes.
Thank you. Thank you so much. It was such a wonderful panel discussion, very excellently moderated by Dr. Sujata Darg and Amay. You are fabulous. The case selection and the actual case selection which you have managed and so beautifully managed. And heart disease is something which always is a challenge to manage also, to discuss also. And you have highlighted so many salient points and very apt take-home messages. And we had this all panelists, Dr. Arun Nayak, Suranjan Chakrabarti, Danny, then Gunjal, Surekha, and they all have so much vast experience in the heart disease subject, and they have done much justice to the topic. And I have got so many positive comments and viewers from all over. People have been listening to us from all over, and they're complimenting and congratulating for this panel discussion. So it's a real fantastic discussion. I thank all of you for being the part of this panel discussion. And as we said, Amay said, Valentine's Day is coming. So let's take care of our heart and also heart of our patients as a doctor. Thank you so much. And I thank Suchitra madam and Dr. Rajendra Nagarkar. Yeah.
Integra's for and as well as Science Integra for coordinating this particular program for us.
Yes, yes.
And please, Komal, your main request, please become members. I don't know. ISOPAB.
Thank you, ISOPAB MOGS, for inviting me and be a part of this excellent program. Thank you, everybody, every members, and including Sujitra ma'am, she's very close to us. Thanks, Komal. Again, such a wonderful panel discussions and moderator. Amio Munjal is excellent. Very good. My extreme regards to all my panelists. Okay.
Thank you.
Thank you, everybody. It's a nice.
Thank you
very much.
Thank you, doctors, for your time.
Thank you.
Suchitra madam, Komal madam, Amia sir, Dalvi madam, thank you so much. Thank you so much. And all the panelists, thank you.